the count of 3, 2, and 1.
A very good evening to all, and while Dr. Preeti Dubey gets her screen share started, may I have a few words from Dr. Kishore Mahapatra, who leads the chapter in Odisha. This is truly a fantastic achievement. We had a really excellent attendance last time, and we look forward to another attendance this time. A few words from Dr. Kishore Mahapatra and how he has achieved this so fantastically.
You unmute yourself. He's not.
Dr. Kishore, you have to unmute yourself. Yes.
Unmute. Yeah.
Yeah. No, you're muted again. Unmute. Yes.
Am I audible now, I think?
Yes.
Yeah.
Am I audible?
Yes.
Yes.
Okay, thank you. Can we start right now?
Yeah.
Can we
Go
start?
ahead. Go ahead, sir.
Well, very good morning. I'm sorry, very good evening. I, on behalf of Society of Fetal Medicine Odisha Chapter and Odisha Sonologist Association, I welcome all the faculties and the delegates to this today's webinar. This is the second time we are coming. The first time we had it on 31st of October, 7 p.m. This time, so because it is a vast subject, we thought that we will not be able to complete it in one session. So we are having a second session today, that is 7th. For today's webinar, we have faculties, Dr. Sakurana, Dr. TLN Parvin, Dr. B.S. Ramurthy, Dr. Chinmay Rath, and overall Dr. Arpita
Rachita. Rachita Ramurthy.
Ramurthy, yes.
Yeah.
I think she is Dr. Ramurthy. Welcome. On last meeting, we missed Dr. Chinmay Rath's talk because there are some glitch or some technical fault. So we requested her to present her paper today, and she agreed, and we are happy for that. That's why we at least we started. We're starting today half an hour earlier so that she can cover her chapter, and as usual we can cover all the faculties today's faculty present. So without wasting any more time, we can right away start the seminar. I would like to request Dr. Purana to take over and do the
Yes.
Thank you.
Thank you, Dr. Kishore Mahapatra, and congratulations once again for such a vibrant chapter of the Society of Fetal Medicine. And I greatly appreciate that how Society of Fetal Medicine is working together in that region with the Odisha Sonologists Association, so that we can work together to make sure that the patient receives the best deal ever. We have Dr. Preeti, who's now ready to share his screen, I think. Dr. Preeti, is your screen share working? Can we move to full screen? And then perhaps we can find out, or we could do this in the break that we had originally kept. If you can go to full screen, then we could do that. There must be a full screen option below. It's usually bottom right, unless you're working on a Mac, in which case you'll find it bottom left.
It's there. Yeah. Oh, yeah, there.
Yeah. Wonderful. Now we see you full screen and we can hear you too. A little louder though. Yeah.
Can you hear me, sir?
Yes, now we can hear you. Yes.
Good evening, everyone. I welcome you all to the second part of the fetal neurosonogram from confusion to clarity. Greetings from Orissa. Next. Greetings from Orissa, a land of sun, sand, and sculpture with rich in culture and heritage. At the outset, I will thank Dr. Ashok Khurana sir and Dr. TLN Praveen sir for giving this platform and opportunity to Odisha chapter of Society of Fetal Medicine. The Odisha chapter of Society of Fetal Medicine was inaugurated on 11th of July 2015 by Dr. Ashok Khurana as chief guest and Dr. Sujata Mohanty, a renowned gynecologist of the state of Odisha, and in presence of local giants in the field of fetal medicine of the state. Initially, we began the chapter with 20 members, and later on, the number has increased exponentially year after year. The first conference, which was held as 3D/4D workshop by none other than Dr. Ashok Khurana. In 2016, we did our second annual conference on the topic of back to basics, that is basic of ultrasound. In 2017, we did our third annual conference on first trimester scan screening and anomalies, which was well appreciated by the state media. In 2018, we did our fourth annual conference on obstetric and gynec Doppler, and in 2019, we did our fifth annual conference on basic fetal echocardiography, which went very successfully. In 2020, we planned for the fetal neurosonogram, and thus we are landing on this virtual background. In 2018, the Odisha chapter of Society of Fetal Medicine received the prestigious President Award for spreading of USG in the grassroots level. Last but not the least, we congratulate Dr. Samarendra Mahapatra for getting second prize in e-poster presentation in an international virtual congress from SFM. Being a SFM member is always a proud. You get a free access to all quarterly meeting, as well as you get 20% discounts on all SFM CMEs, including the international congresses of the Society of Fetal Medicine. And you get many e-journal free. So now many young fetal medicine specialists have come back to the state. So I welcome all of you to please join our SFM family. We are having bunches of benefits. So to introduce today, first speaker is Dr. Chinmay Ratha, who will talk about the basic neurosonogram. We missed her last time because her computer was not working. The next speaker is Dr. Ramamurthy sir, and he will talk about applied aspect of neuroembryology. I will suggest to read this book of imaging of fetal brain and spine. It is written very excellently. The next on the dais is Dr. Indrani Suresh, who is the director of the Mediscan system, my teacher, and she will talk about the abnormal CSPs. Next is the Rachita Ramamurthy. She is the daughter of Ramamurthy sir, like father, like daughter, and she will talk about approach to see the ventricle. Last but not the least is our own president, Dr. TLN Praveen sir. Ever smiling face, he will talk about posterior fossa lesion. And the giant, and lastly, I will thank Mr. Vishal Mittal and Mr. Sumit Ghai for smooth presentation. Thank you and all.
We're all set for Dr. Chinmay to go on with her slides. We see your full screen marvelously, and we're waiting for your audio.
Yes, sir. Good evening, sir. And at the outset, thank you very much, sir, and the entire SFM organizing team and SFM Orissa chapter for allowing me to present my presentation this week. Sorry for the problems last week. And as Preeti has shown, it's been a brilliant journey with SFM Orissa through the beginning till now. And I feel proud being part of all your activities since the inception. Wish you luck in future. Now, in this journey of doing the fetal brain anatomy ultrasound in mid-trimester, the topic that I have been allocated is standard views of the fetal brain at the TIFFA scan to the neurosonogram. Now, standard views are the views which all of us should feel comfortable in achieving while we are doing a regular anomaly scan. Now, fetal brain imaging, the views depend on gestational age. I'm sure last week, Dr. Sudarshan would have shown us the entire first trimester imaging of the fetal brain. And it's marvelous to read that the brain is an organ that is constantly developing and differentiating. In fact, if you read Ramurthy sir's book, in the very beginning, he said, with the humble origin from 3 vesicles, it goes on to become a very complex structure. And that book, which Preeti just showed, is a must read for everybody. I mean, without reading that book, I don't think we should proceed imaging the fetal brain at all. Having a teacher like that amidst us is an honor and is a blessing, actually. So this organ is constantly developing and differentiating, and a very complex and potent organ which regulates almost all our bodily functions. In the adult stage, we know how important the brain is. But although the structure and function are not exactly congruent, every brain that looks normal will not function normally. But every brain which looks abnormal has a high chance of abnormal function. And therefore, it is imperative during fetal imaging to find out any abnormalities that are possible to be detected, because that gives the first clue that this particular fetus might have brain dysfunction later on. And that is a huge quality of life issue and needs information for the parents. So when we do the targeted imaging for fetal anomalies, we usually do it in the second trimester between 18 to 20 weeks. Sometimes again, we look at the baby at 22 to 24 weeks. And in the third trimester, while we are doing the growth scan, we look at the brain beyond 28 weeks. So when we call TIFFA, the purpose and the scope of imaging the brain in TIFFA is targeted imaging. And some standard views have been recommended in the brain during a regular TIFFA. These have to be done in all cases. But then there is another entity called a targeted fetal neurosonography. And this is little different from the regular standard views because it is a dedicated multiplanar diagnostic approach for fetuses who are actually at high risk of fetal anomalies or have some suspicion of anomalies based on their preliminary examination in the standard views. So we should remember that every fetal scan which is done involves looking at the fetal head, because biometry starts with measuring the head circumference or the biparietal diameter. But it is not uncommon that while biometry is done on everybody, very many times fetal brain anomalies are missed or brain details are not seen. And one of the primary reasons of that is this statement, which my teachers have told me from the first day in medical school, that what the mind does not know, the eyes do not see. And I tell you from personal experience that the way we were looking at the fetal head, the way we were looking at the fetal heart 15 years back has changed, not because something new has started occurring in that brain and the heart. It is the same kind of human physiology has not changed, human anatomy has not changed. But the way we look at it, because of the technology of the machines available to us and the ability to interpret it because of the knowledge of embryology and other allied sciences, we have started interpreting it better. So what do you require? You require a good machine with good real-time grayscale imaging, transducers, which can do abdominal and as well as vaginal transducers, adjustable acoustic outputs, freeze frame capabilities, electronic calipers, capacity to spin and store images, and regular maintenance. These are all standard requirements for any anomaly scan. For brain assessment particularly, what is important is a good resolution machine, grayscale and color imaging, curvilinear and linear probes, transabdominal or transvaginal, depending on that, whatever frequency you may use from 1 to 9 megahertz. But most importantly, the operator's brain has to be trained to see the fetal brain correctly. Because again, what the mind does not know, the eyes do not see. So the ISWOG has given some guidelines about the mid-trimester scan, wherein the basic things that are required for a checklist for a fetal central nervous system assessment is the head shape, the lateral ventricles, the cavum septum pellucidum, thalami, cerebellum, cisterna magna, and spine. So these must be covered in your standard views of the second trimester scan. Now, let us see what all can go wrong here. So in the head shape, a normal head shape is an oblong head shape the way we saw here. It has a biparietal diameter and an occipitofrontal diameter, and it looks a little oblong. Sometimes you don't see the head at all. So this is an encephaly, or you may see abnormal protrusions from the head as in encephalocele. The head shape may sometimes be a little different from the normal oblong. It may be too oblong like this, which is called dolichocephaly, and a little roundish, which is called brachycephaly. Now, if you just define it as, oh, this looks a little round, this looks a little long, that becomes very subjective. So there is an entity called cephalic index. What you can do is you can measure the biparietal diameter and the occipitofrontal diameter separately, and then you take a proportion of that and multiply it into 100. A normal range of 71 to 78% would be a normal range. If it is lesser than that or it is more than that, it's either brachycephaly or dolichocephaly, as the case would be. Now you see here that people who rely on the biparietal diameter for biometry often send referrals as small head when they see a dolichocephalic head. But if you look at it carefully, here the biparietal diameter would be a little smaller, but it will be compensated by a longer occipitofrontal diameter. So the actual head circumference remains almost normal in both the cases. So in most of these cases, they are normal variants. Sometimes they may be associated with other pathology, where dolichocephaly may be associated with, it's very commonly seen in normal breech presentations, but it may be associated with some abnormal fusion of the sutures, or a small head, or a brachycephaly may be associated with trisomy 21. So if there is no other feature, they may be a normal variant, but it's good for you to look at the cephalic index, work it out, see the shape of the head, and also see the head circumference and look at it in serial measurements that it is growing. So head shape assessment, that much should suffice in the standard thing. Sometimes you get abnormal shapes like this. Like this is a particular case. You see the sagittal suture had fused very early, and you look at this shape, it is called a clover leaf head. This was detected late in pregnancy, unfortunately. But then, you know, the baby came out, it had a bit of dysmorphism, and the neurosurgeon had a look at it, and he said it is correctable. This is because of craniosynostosis. Some sutures have prematurely fused, and this baby underwent surgery, and some reconstruction was done with biparietal release, and she is quite nicely growing now, doing very well. So some of these can be corrected as well. Some of the shape abnormalities may be because of problems in the spine. For example, you can have a lemon-shaped skull because there is an abnormality in the fetal spine. When you have a lemon-shaped skull, it is often associated with a banana-shaped cerebellum. See, this is a normal cerebellum which has a dumbbell shape, but sometimes the cerebellum starts looking like a banana there, and that's because of the herniation of the contents in the posterior fossa into the spinal canal because of a protrusion in the spine like a meningomyelocele, as you can see here. So when you see an abnormal head shape, it is imperative to look at the spine. That is why, if you remember the checklist, while it is about measuring, like looking at structures in the brain, it ends with the examination of the spine, because the spine and the brain are so closely related that a problem in the spine will reflect in the brain, a problem in the brain will reflect in the spine. So you can see here that there's an abnormal head shape, but the actual culprit is not in the head, but in the spine. And this can be a lemon-shaped skull, as this thing may be. So while we're talking about spine, let's just finish off spine quickly here. In the standard examination of the fetal spine, it is suggested suggested that the spine is investigated in the sagittal, coronal, and transverse sections. And as you can see here, you will get a very good spine is bony, and therefore you get very good resolution on your ultrasound, and you can look at the arrangement of the vertebra. And when you look at it in the transverse section, you can see for the ossification centers of all the vertebra, and you sweep across to see that there is a good smooth covering of skin over it. There are no abnormal protrusions. And if you look inside it, you can actually see the ending of the spinal cord there, and the level of the ending of that spinal cord, which is called conus medullaris, depends on the gestational age that you see that. So head shape and the spine we have covered so far. But still what remains now is looking at the lateral ventricles, the cavum septum pellucidum, the thalamus and the cerebellum, and the cisterna magna. So if you see, when you look at your axial investigation of the fetal head, you will be actually seeing all these structures. You just have to train your eyes to look at those structures in a way that you appreciate whether they are normal or not normal. And this is part of routine TIFFA, mind you. We have still not reached a stage where we are talking about some specified neurosonography. So whatever we have measured or checked till now is expected of everybody who is doing a routine TIFFA scan. So after looking at the head shape and checking the integrity of the spine, you look at the head in a fixed axial view. And the three axial views that we do for every anomaly scan are the transthalamic view, the transventricular view, and the transcerebellar view. So if you start with the transventricular view, you see you cut across. Every time looking at these pictures is a good idea for those who are unable to correlate the ultrasound pictures with the anatomy that exists, because it reminds you where are you looking at this brain. So this is how the ventricle looks. So you see there is an anterior horn there, there's a posterior horn there. So when you are cutting through this in the axial section, you should see both the ventricles on each side. You see a midline division, the falx cerebri here, and then here in between you will see the cavum septum pellucidum, and in the ventricles you see the choroid plexus there, and then you can correlate all this on your ultrasound picture. So you have the cavum septum pellucidum there, you have the midline falx cerebri there, you have the ventricles there, and just at this ending of the choroid plexus, the glomus here, or the parieto-occipital fissure there, this is where you measure the ventricles. So this is the transventricular view of the fetal head. And here you look at the lateral ventricles. So you measure the ventricles at the level of the glomus or parieto-occipital fissure. The calipers are placed along the inner borders of the ventricular wall. So you look at the ventricular wall here, along the inner border you place it, and any measurement up to 10 mm is considered to be normal. Now you would notice here that it is very easy to look at the distal ventricle because that comes within the frame very easily, but to see the proximal ventricle, the acoustic shadowing often makes it difficult for that to be seen. So you may have to tilt your probe a little and go there and see it. But once you see it, you measure both of them. Sometimes what we do is we split the screen and measure both at the same time and show, so that there is no confusion that both of them were measured. That is a unit to unit protocol. You can do it whichever way you want, but that just helps in reminding you at the end of your scan that you've already measured both the ventricles. That should be part of your TIFFA assessment. Now, a normal appearance of the ventricles and an abnormal appearance of the ventricles must be appreciated. So when you look at these ventricles, normally you see the posterior horns and the anterior horns, and sometimes you can see a bit of that corpus callosum coming in there. But when you see abnormal shapes like this teardrop ventricle with the frontal horns very far away from each other, you start suspecting that there is something wrong in this thing. So you've till now only done axial views, but in the axial view, you've now got a clue that something is not right and perhaps this brain needs further investigation. So this fetus will be a candidate for a detailed neurosonogram, about which we will talk later. Then in your normal checklist comes the CSP, or the cavum septum pellucidum, and that is structure right here in the middle, where you can see it like a rectangular structure, and it appears around 16 to 17 weeks, and then till about the end of the pregnancy you can see it there. and it's usually less than 10 millimeter in width there. So first it should be present, and second its width should be within 10. So here you see you're not able to appreciate the cavum septum pellucidum well, whereas here you appreciate it very well. So in these two conditions, Indrani ma'am is going to talk about the abnormalities of the CSP, but suppose you do a normal scan, you should be able to see that structure there. So we have to train our eye to be able to see that cavum septum pellucidum at that region in the proximal 1/3 of that fetal head there in every scan. If we don't see it, then we have to suspect that there are problems and move on to further investigation. We'll have a detailed session on that later on, but this is how, when you look at here, you should not start imagining the CSP there. I mean, this is a brain where we could not see a proper structured fluid-filled structure there. So if we don't see it, we don't see it. We should not try and imagine and think that there is a CSP there, because this is where we miss abnormalities. Coming to the next axial view is the transthalamic view. And the transthalamic view is, again, one of the common views where we take the fetal biometry. Traditionally, we measure the biparietal diameter here. Some people measure it even in the transventricular view, but traditionally it is done in the transthalamic view, and it is identified by the presence of the thalami across the midline here and the hippocampal gyrus. So we can see the frontal horns of the lateral ventricles, the CSP, a bit of the CSP, the thalami, and the hippocampal gyrus. Then the transcerebellar view is when you just tilt your probe a little bit more, and in the presence of the CSP, you tilt it and you start seeing the cerebellar hemispheres, which come across like a dumbbell shape, and they are connected in between by it's a butterfly shape structure there, connected in between by an echogenic structure, the cerebellar vermis. So the vermis, if you can see, appears a bit more echogenic than the rest of the cerebellum there. And the biometry that is taken here is the transverse cerebellar diameter and the cisterna magna, which is measured from the posterior border of the cerebellar vermis there up to the inside of the occipital bone. And this cisterna magna should measure between 2 and 10 millimeter in pregnancy. Anything more than 10 millimeter is called megacisterna magna, and it may be either an isolated megacisterna magna or associated with other problems. Again, I'm sure that will all be dealt with posterior fossa anomalies later on. So in the normal appearance of the transcerebellar view, we should see a continuous cerebellar vermis orientation like this, with no breaches and no abnormalities there, because sometimes you see things which are not reassuring, like instead of that normal dumbbell shape, you saw a banana cerebellum when we were looking at spina bifida, and here you see some abnormal cystic structure which is communicating with the ventricular system there, and you suspect things like a Dandy-Walker malformation. So this was one of the fetuses which got terminated, and autopsy was done. Pictures, these are beautiful pictures rendered by Dr. Sunil Jaiman, our perinatal pathologist. But this is just to highlight that these are the problems that you could pick up by the transcerebellar view of the fetus. Now, even though we could pick up a lot of problems in whatever we could see in the traditional axial planes, due to the complexity of the CNS development and malformations, and there are limitations of the assessment also, because of acoustic shadowing, the proximal part of the brain is not seen very well. We don't look at the midline structures very well in these axial planes. So that led to the emergence of the concept of fetal neurosonography. And neurosonography is a very fancy term, and it's a very intimidating term. Ramurthy sir will laugh when we say that, but sir, brain really worries us. I mean, I used to be really terrified of the brain, and I used to listen to your lectures with like utmost concentration, and thanks for the book, which made it even more easier for us to understand. But the point is, neurosonography sounds too big, but it's nothing but a section-wise analysis of the brain. And when we say multiplanar, we are just looking at it in 3 perpendicular dimensions. So it is a multiplanar diagnostic examination of fetuses at high risk or the fetuses where we suspect CNS or spinal malformations. It has much greater diagnostic potential than the screen. So whatever we have done till now is the standard screening examination, and it neurosonogram helps when you are evaluating complex malformations. It definitely requires a higher level of expertise and sometimes may need the assistance of a transvaginal approach or even a three-dimensional approach. But three-dimensional is not mandatory to do a neurosonography. You can do it even with your two-dimensional thing if the baby is in good position. And in addition to the planes that you use in screening examination, you add to it the coronal and the sagittal views. So indications for neurosonography are pretty much similar to the indications like you have in fetal echocardiography. So when you see something in the basic examination, you go ahead and do an advanced echocardiography. So this is very routine. I'm not going to read the whole thing, but anywhere where you suspect the baby to have further brain abnormalities becomes an indication to go ahead and do a detailed brain evaluation in all possible dimensions. And that is exactly what is neurosonography. So when you do neurosonography, you require a high resolution equipment, deep knowledge on the part of the professionals who perform it, who have studied the embryology and the anatomy of the CNS. And the objective is to identify manifestations of cerebral malformations to, work up a certain problem and give appropriate counseling for prenatal follow-up treatment and postnatal prognosis. And remember, what the mind doesn't know, the eyes do not see. So you have to know what you are examining while you are start doing these things. So these pictures look very complex, but you just put your head around it. It is not at all complex. That is a head. Head is a round structure, and you are going to see it by putting your probe by this side, this green line, that will give you the axial views, because you're cutting an orange from where you want to cut it and get two equal halves of that orange. If you cut it just perpendicular to that, this is a sagittal plane. You rotate it from that area. Why not parallelly shifting? Because the window is here. You're going through the anterior fontanelle. So you just tilt your probe this way, and that way you get what are known as parasagittal planes. So you get a median sagittal plane and you get parasagittal planes. And then if you start looking at the face and go backwards like that, that is called the coronal cutting. So you can either get axial views, or perpendicular to that you can get the sagittal and the parasagittal views, or you can just come straight away like that and get the coronal views. So these axial views were part of our routine examination, which we have already done. If we start calling it a neurosonogram, we will have to add 4 coronal planes and 3 longitudinal planes. The longitudinal planes are nothing but the median sagittal plane. It's not mid sagittal, but median sagittal, and then parasagittal to the left and parasagittal to the right. So that is done from this angle. You go there and just turn it here. This, I have taken a picture from a neonatal neurosonogram because that's the closest that we can get to while doing examinations. And this coronal planes is nothing but, all of you are familiar with getting the lips and the nose. The nose and the lips, we look at it in the coronal plane, and in just that plane you keep moving your transducer parallelly, you will get all the coronal planes that you want in the fetal brain. So again, this is for you to put your mind across that what are we examining when we are putting our probe in a way and imagining that we should get that particular view. What are the structures we are encountering? So if we go abdominally, and this is where we put it, it's easy to imagine. Suppose the baby is head down and you have an access by transvaginal probe and you put it across one of the windows like the anterior or posterior fontanelles, you can actually get these views from there. And when you rotate your probe 90 degrees, 90 degrees, 90 degrees, you will keep getting the corresponding perpendicular plane. So in the extended views, apart from the axial, you go at the coronal view. And look at this, I just told you, go to the nose and the lips view and just keep moving parallel from there. So that is where you will get the coronal, the 4 coronal views, mind you. And it's very simple: transfrontal, transcaudate, transthalamic, and transoccipital. So here you are, this is the transfrontal plane. Just imagine this view, and this is where you're looking at. So the ventricles have not yet started. So you're not going to see the ventricles. Instead, you will see an uninterrupted interhemispheric fissure. You may see the orbits down there. That is the frontal cortex of the brain. Sometimes a little bit of the frontal horns of the lateral ventricles. So Here you see the sphenoid bone. So this is nothing but the transfrontal plane of the so-called neurosonogram. Then you go on to the transcaudate. So here you're crossing across the caudate nuclei, and you see a triangular cavum septum pellucidum there. I don't know what happened. These frontal horns of the lateral hemispheres, and again the interhemispheric fissure, which has just started to get interrupted by the corpus callosum there. So this was transfrontal. You've just moved in parallelly a little posteriorly, and that is where you're getting transcaudate. So caudate nuclei, interruption of interhemispheric fissure by the anterior portion of corpus callosum, CSP, frontal horns, and the sylvian fissures bilaterally. Now, this is all I've copied it from textbooks because I can't recreate anatomy or reinvent anatomy there. But it's important for us to understand it because, you know, if we don't put our head around it, it looks very complex. I used to be very intimidated with the neurosonogram, I'm telling you, but the moment you start interposing the anatomical pictures along with the pictures that you're getting on your ultrasound, you will understand where you are, and you know, that hand-eye coordination will come. Then comes the transthalamic plane. So here it's just a little posterior there, and what you see in addition to other things is your the third ventricle, foramen of Monro, and if you put color there, you will be able to see vessels which are forming the circle of the Willis, and optic chiasma at the base of the skull. Then you come to transcerebellar plane, which is now again posterior there. So only you see the occipital horns of the lateral ventricles, and deep down there you see the cerebellum, the cerebellar ventricles, cerebellar hemispheres, which are connected at the level of the vermis. So if you pay attention there, you'll see the ventricles and you'll see a midline vermis there like you see here. So these are 4 coronal planes which you have achieved by just moving your probe, what is called translocating your probe from the the face view, that frontal face view, you keep going backwards. Of course, babies keep moving and it's not so easy always to get it. And that is where I think sir will tell us that 3-dimensional is going to help us get the image quickly. But suppose you're not a very 3-dimensional person, you can just keep translocating and you will get all the 4 views there. Then you have got the sagittal planes, which has the median sagittal plane and the and these 2 images are important to keep in your mind. I have taken them from the article of Professor Itsuko Pu, where it's an article free access on the internet. It gives a very nice assessment of how to look at CNS anomalies on ultrasound. She's concentrated more on 3D ultrasound, but still, this is important that you understand these anatomical structures, and when you're looking at them in mid-sagittal view. In mid-sagittal, you will look at this view, whereas if you go parasagittal, you will be concentrating on the ventricles and their cortex alongside. So in parasagittal view, it's also called the 3-horn view. You're basically looking there, turning from that anterior fontanelle and getting this plane into your picture, and therefore you can see the occipital horn of the ventricle and the cortical structures above it. So that is parasagittal. The next thing I have to learn from Ramurthy sir is to put a bookmark on my videos the way he does, so that I reach exactly where I'm supposed to reach. But till that time, bear with me. You can just see that occipital horn, which is like sprouting out there. So that is parasagittal. From midline, you turn to the sides and get your parasagittal view. So then in your median sagittal view, you will look at this very important structure called the corpus callosum. And last year, when we had the neurosonography module here in Hyderabad, Dr. Mohit Shah took us through a very interesting anagram of telling us that it was rostrum, genu, body, and splenium. I am not going to repeat the code he gave us, but just remember, okay, and if you can't remember that, you can just say read, guide, study, read, guide, brag, and study. I learned it that way, but whatever it takes, it's rostrum, genu, body and splenium, and you have to appreciate all the parts of the corpus callosum in that medial sagittal plane. And in that same thing, you look at the cavum septum pellucidum, you look at cavum vergi behind it, structures of the brain stem here. You see the vermis, which I have always remembered Professor Ramurthy tell us that it lights up that screen. You know, you just, it's such an echogenic structure that it just catches your eye the moment you see the vermis. So when you see here, amidst all this gray, suddenly there is a white track there, and you recognize that the vermis is very much present there. Then, of course, the assessing the corpus callosum is an important part in antenatal scans. And believe you me, if you try to do it regularly on your mid-trimester scans, you will get into the habit of doing it. And these are all 2D pictures. So far, no 3D has been used in this assessment. So if you look at the abnormal shape of a ventricle, like a teardrop ventricle, that is an indirect sign of corpus callosum agenesis. And these are all schematic pictures which are available in textbooks, which will give you an idea of what to look for when you suspect some abnormality. Whenever there are abnormalities in the standard views, like in this case, the head was small, there was a flat profile of the face, and the ventricles look large, that is an indication of doing neurosonography. And neurosonography is nothing but a multiplanar analysis for better understanding. And you will only get better understanding when you anatomically know which structure you're looking at and how will it look from one angle to another angle. So what you need here is you do either you image everything separately in 3 different planes like we saw in the preceding slides, or you do a 3D acquisition. So once you acquire it, you get it in all the 3 planes at the same time, that is the axial, sagittal, and coronal. So it becomes an easy method, a time efficient method, and a method which can be used to process, analyze, and teach others. Even after the patient has gone from there, you can do a thing. This is again from Dr. Poo's article, this picture. This is nothing but computerized tomographic imaging, where you see the sections have been taken. I was telling you, you have to translocate your probe from one plane to another plane to another plane. Here, the computer has taken the entire volume and given you sections. What would you see at this plane, this plane, this plane on its own? Whereas if you were doing it manually, again, I don't know, that thing is not, but if you are doing it, it will just translocate it in the same way and take you from the transfrontal plane to the occipital plane like that. So here, this is this is a 2D picture of the axial view of the cerebellum and the vermis. And suppose you wanted to, this is the vermis right there in between. And suppose you wanted to do an acquisition. This is a very basic demonstration of how to acquire that. You go there and you go multiplanar, so you can see the vermis in the sagittal section. So these are just, I mean, this is just to tell you that this is how you do it. We have masters here who will teach us about 3D acquisitions, but just to tell you that either you do it in 2D when you know you're sure of your anatomy and your position of the baby. If you can't get that, 3D is there to assist you to acquire it and do a post acquisition processing. So 3D just makes life easier and quicker, and it's a time efficient and a more demonstrable process as opposed to a 2D, which is very much dependent on the baby's position, and sometimes it takes a lot of time to acquire those planes. So nowadays we have fast acquisition of 3D and we are able to do much more assessment with that. But 3D helps even with good 2D neurosonography is possible. It is not, 3D is not completely mandatory for doing a neurosonogram. So to summarize, the standard views on doing a TIFFA would be the head shape, lateral ventricles, cavum septum pellucidum, thalami, cerebellum, cisterna magna, and the spine. This is mandatory. This is the ISWA guideline which says this has to be checked in each and every baby. If you go on and think that I want to do something more because I suspect that ventricle is looking a little large, or I am not able to see the CSP very well, then you have to do the rest of the rigmarole, which includes 4 coronal planes, transfrontal, transcaudate, transthalamic, transcerebellar, and 3 longitudinal planes, which is the median sagittal plane and the 2 parasagittal planes on the right and the left side. So what you need to do is get used to the standard views. Once you are used to the standard views, at least you will reach that stage where you will be able to say, no, this is not normal, because most of our patients need that information. We must tell them whether this is normal or not normal. After that, we are not able to classify that abnormality. That's another level in itself. At least if you are able to triage them into normal and not normal, your first step in fetal brain assessment is done. Once you see something, you correlate it with the expected anatomy, and then you can diagnose the problem. For that, you need to keep learning. So remember, brain itself is a constantly evolving structure, and so is the learning about the brain. So just like every time, every day or every stage of life, the brain evolves itself. Learning about brain also evolves itself. So it starts from a very basic plane to plane approach to all the fancy things that you will be now told about. Just the CSP has a lecture for 20 minutes. Just the posterior fossa has a lecture for 20 minutes. And Professor Ramurthy can take you the whole day on corpus callosum and the cortex with proliferation, migration, and organization. But to begin with, it's a good thing to look at all your standard views. And this journey continues, and enjoy the journey. Thank you very much for giving us an opportunity to share some learning with you. With that, I hand over the mic to the organizers.
Thank you, Chinmay. And we move on to and we will have questions at the end of this session, which is after the next two talks. We now have Dr. Ramamurthy, who will speak to us on the applied aspects of neuroembryology. Dr. Ramamurthy, may I request you to share your screen, please?
Yes, is my screen seen?
Yes, and we can hear you very well. Thank you.
And is the arrow moving around?
Yes.
Yeah. At the outset, again, congratulations to SFM Odisha chapter. And thanks Ashok, Dr. Hasmukh, Dr. Preeti, Dr. Praveen for asking me to take part in this evening's proceedings. Now, we've had Dr. Chinmay come up with a solid foundation. She's put us on course as to what ultrasound can do as far as the prefetal brain goes. And I'm extremely happy to say that she's referred to embryology at least twice in her lecture. And that is what we're going to do now. And we're going to look at embryology and see how it helps us in day-to-day practice. So what I'm going to do is to give you landmark events, embryological events. And then what is the fallout of that event as far as ultrasound of the fetus or the fetal brain goes? Now, in the process of doing that, we will understand two things. One is, what is the basis of the abnormal anatomy? When we look at an abnormal fetal brain, why has this abnormality occurred in terms of embryogenesis? And most importantly, what is the timeline of the abnormality is also what we're going to study, because embryological events occur at certain periods in embryological, embryonic or fetal life. And we need to recognize that that timeline helps us in day-to-day practice as well. Right. So the first event that we will look at is primary neurulation, and for primary neurulation is formation of the neural tube. From a plate, it becomes a groove, and the groove closes to yield or form a tube. And this entire process is driven by the notochord, and it's called dorsal induction. Now, the neural tube formation from the folds to groove to tube is all over by 28 days of conceptual age. So therefore, what is conceptual age? It starts from the day of conception, but we are not used to the conceptual age. We are used to gestational age. So the simple trick is to add 2 weeks to the conceptual age. So when 28 days is 4 weeks, 4 weeks conceptual age is 4 plus 2, which is 6 weeks gestational age. So by about 6 weeks gestational age, the entire neural tube is done. From the cephalic to the caudal, the entire tube is closed, though not in the same order, right? Now, total failure of the closure. What if this neural tube doesn't close at all? Now, what you get is craniorachis, and craniorachis is the most severest of the open neural tube defects. So whenever the neural tube closure is a problem, you use the term spinal dysraphism, open neural tube defects. These signify the fact that it's a failure of dorsal induction. Now let's look at this case. Here is the orbits are seen, but I don't see the calvarium. I don't see the calvarium. When I go to the spine and do a transverse section, that's the anterior center, posterior centers, very wide apart, no skin. And when I do a coronal and sagittal, I find that the coronal, the posterior centers are really spaced apart, and the spinal canal is laid open and wide, right from the cervical down to the sacral region. And there's also kyphoscoliosis. So this tells us that the entire spine, right from the caudal neurocephalic neuropore down to the caudal neuropore, is laid open. It's not laid open, it simply refused to close. It's not that it was closed and then somebody laid it open. No, it refused to actually convert itself from a groove to a tube. And this is the most severest lesion in the spectrum. Now, what other problems can occur? If the entire neural tube closes except the rostral end, you'll end up getting the anencephaly, and you'll see the brain popping out. There is no calvarial bone surrounding, and the brain is actually exposed to the amniotic fluid. The orbits look prominent. That's the classical frog eye appearance. And this again is the fact that the orbits are seen well, but the cranial calvarial bones are missing. And again, the spine is normal. So this is the classical acrania anencephaly spectrum that you have. Starts off with acrania, no calvarial bones. The cerebrum, the exposed tissue gets proteolized, and ultimately you have a anencephaly, and that's failure of closure of the rostral end, the upper end of the neural tube. Now, if there is failure to close of the caudal end or caudal segments of the neural tube, you get the classical lumbosacral or sacral open spina bifida. And I've chosen a first trimester example to bring forth the importance. And this is a first trimester nuchal translucency or first trimester anomaly scan window. And in the mid-sagittal magnified picture, the kind that we use for the nasal bone, the NT, you also have the IT now, and the IT here is distorted. The brainstem is wide, and the brainstem occipital bone distance is reduced. So I know that there is a screen for positive finding as far as an open neural tube defect goes. So on transabdominal ultrasound, I'm able to see something happening in the spine here, but you switch probes, go on to transvaginal, and on transvaginal, you can beautifully show the open spina bifida. There's also a diastematomylia spine, a mid spur out there. Posterior centers are splayed apart, and that's the anterior center there. The skin continuity is lost, and there's a meningomyelocele. Also, in this particular case, we see that, yes, there is a sign, the banana sign, which is coming already. And when I go up into the thalamo-peduncular view, I find that there's a parallelism which is occurring. The parallelism which is occurring, and the fact that the aqueduct of Sylvius is moved closer to the occipital bone. So both the intracranial signs on axial planes as well as the local signs on of the spine, all actually prompted by the screening parameter here, where the intracranial translucency is distorted and the normal anatomy is lost. Now, after having seen what can happen, what can go amiss as far as the primary neurulation, we move on to secondary neurulation, and this contributes to the neural development caudal to the caudal neuropore. And it occurs after primary neurulation, and that is why we call it the secondary neurulation. This is between 35 to 42 days of conceptual age. So what are the structures which are coming up due to the process of secondary neurulation? The conus medullaris, phylum terminale, the spine, caudal to S3, all these are the structures which develop thanks to the secondary neurulation. Defective secondary neurulation results in closed spina bifida, in contrast to the open spina bifida, which occurs due to defects in primary neurulation. Let's see an example. Here is a 24 beaker. I've used a 9 megahertz linear probe, and you can see the posterior centers, the anterior centers. You can see the conus as a hypoechoic cone-shaped structure terminating there. Now I count the last ossified segment in the sacrum, the visible last ossified sacral segment as S4. And if you count that as S4 and go upwards, you will find that this is L5, L4, L3, and the conus is always above the level of the lower border of L3 in the second trimester. Now let's look at this particular case scenario. I've done the same thing, but I've used a convex array probe over here. That is the last segment. The trick here is to get your pure mid-sagittal section. When you get a pure mid-sagittal section, you actually cut between the two posterior ossific nuclei and you go straight into the vertebral canal. And that's exactly what happens here. This is the last sacral spine. So S3, S4, S3, S2, S1, L5, L4, and you find that the conus has come over here all the way down below L5. And I have counted here, that is the conus level, that is L4, and it's abnormally low. You can also measure what is known as the conus distance. The distance from the last sacral ossified segment to the tip of the conus gives you the conus distance. You have tables, any conus distance less than 5th percentile means a tethered cord, means a conus which is lower down than usual. That means the cord is pulled down and it is tethered. Also, you have the conus distance by algorithm. You can relate it up to the femur length minus 8.2. Femur length in millimeters minus 8.2 millimeters gives you the normal conus length. And if it's lesser than that, think of the tethered cord as well. Now, why did I go and do this particular section here? We don't do it in all cases. We don't do it in every mid-trimester normally scan. But what came forth here as the screening problem, as the screening point is, as I was doing the axial section, you begin to realize that at this level, the posterior ossific centers are subtly apart, and I feel that there is something happening to the form of the posterior ossific centers as well, and that prompted me to go ahead and do the magnified high-resolution pictures that you can see here. Now, remember, all along you find that the skin is continuous, the subcutaneous fat is continuous, telling us that this is a closed spina bifida. And always in closed spina bifidas, there are no intracranial signs. So up in the cranium, you see a normal intracranial, posterior cranial fossa. There is no scalloping, frontoparietal scalloping, bananas, and there are no the oranges either. So no lemons either. So there are no intracranial signs. And whenever you suspect an the closed spina bifida, we need to look for abnormal fatty deposits to say that there is an additional sign, and that is seen over here. In the same case, you see a focal pad of fat here. There's a small little cystic structure in between, and that also tells you that yes, this spine has indeed a closed spina bifida with a tethered cord. Now, having finished primary neurulation and secondary neurulation, we move on to post-neurulation problems. The one typical example is a mesodermal defect which occurs post-neurulation, post-secondary neurulation. Now, whenever there's a mesodermal defect in the calvarium, there is herniation of the intracranial contents outside of the defect to form what is known as a cephalocele or a cephalocele. Now, a cephalocele, I've again chosen first trimester example to show you. That's a transverse, that's a transvaginal scan. You find that the cephalocele is covered always with the skin continuity. There is no discontinuous skin, and that's a little herniation occurring outside of the defect there. So that is a classical occipital encephalocele. Again, an embryological mesodermal defect, focal defect in the cranial or calvarial bone. Now, the same kind of thing can occur in the frontal region. And when it occurs in the frontal region, and here you can see a lot of brain coming out as well, it can push the orbits on either side apart and give rise to hypertelorism, gives rise to hypertelorism. Now, when it occurs in the frontal and the occipital, they are embryologic. that is to do with embryology, but they can occur atypically in the parietal, temporal, wherever. And this is an example, a 13-week example. You find the cranium there, and you have a small little, nubbin of tissue which is projected out. And sure enough, this is not frontal, this is not occipital, and you find a amniotic band tethering the whole thing there. So that is an amniotic band sequence. The important thing is that the embryologic encephaloceles may be associated with syndromes, may be associated with recurrences, whereas an amniotic band syndrome related encephalocele is a sporadic disorder. There is no genetic predisposition. It's not chromosomal in nature, and therefore the importance of recognizing an embryonic etiology versus a non-embryonic etiology extremely important. So the neural tube is completely formed by 28 weeks, and this is just about the time the lady realizes she's pregnant, right? About 5 weeks, and then she, oh my, I've lost my periods, and just about the time the feeling is sinking. By that time, the neurulation is done over completely. And that is why if we have to do folic acid therapy as a prophylactic strategy, we need to hit before the pregnancy starts. And that is why we look at it at least 2 to 3 months before the pregnancy starts. The folic acid has to be given, and it has to be continued for well into the first 3 months of pregnancy. And that would ensure that there's an adequate folic acid coverage. And I've shown you the WHO document of 2002. Right, now we move on to the next stage. Once the caudal and the cephalic neuropores are closed, you have almost immediately the cranial end or the cephalic end of the neural tube expands, becomes broader, and it also develops 2 constrictions, which gives rise to 3 bulbosities or swellings there. That's the prosencephalon, mesencephalon, and rhombencephalon, and these 3 together would give rise to the future brain. That is the plain, simple origin of the brain, right? Now we need to understand that these are called the primary vesicles, and these primary vesicles can give rise to secondary vesicles. The mesencephalon doesn't, but the prosencephalon gives you the telencephalon and diencephalon. And of course, the rhombencephalon gives you the metencephalon, myelencephalon. So telencephalon gives rise to the cerebral hemispheres. The diencephalon gives rise to the basal ganglia. The mesencephalon gives rise to the midbrain. Metencephalon gives rise to the cerebellum, and then the myelencephalon gives rise to the medulla oblongata, the pons, so on and so forth. That's the brainstem. So it's important to realize that these 3 vesicles, 3 primary vesicles, and finally there are 5 vesicles if you add all the secondary vesicles into the list. Now we must understand that today with our high frequency, the wherewithal that we have, the kind of probes that we have for transvaginal ultrasound, and the software that we have to manipulate, to create and manipulate 3D volumes, you can look at embryology as it happens in the embryo, so to say, real time. And this is an example. You see that this is the transvaginal ultrasound. This is a sagittal acquisition. You see the diencephalon there, the mesencephalon, and then the rhombencephalon. This becomes the coronal section. This is the axial section. I put the dot, the navigation dot, actually in the diencephalon. Then you see the telencephalon on either side. That's the rhombencephalon which is happening. And if you do a 3D rendering, and if you use what is known as a solute kind of algorithm, you will see that the entire neural tube is beautifully seen here. And not only the brain is seen, you can also see the flexures, the pontine flexure and the mesencephalic flexure beautifully brought out all in utero. And that's the power of ultrasound, and that's the power of technology today. And this is done at 8 weeks. This is an 8-week study, right? Now let's see what could go wrong at this stage. I am considering day 40, conceptual age. And this is a case where you see the CRL, you see the longitudinal section of the fetus, but I'm not happy with the forehead. This is receding, and that gets my antennae up. I know there's something wrong. And when you look at the fetal cranium, when you do an axial section, you'll find that the entire brain is full of the thalamus, the peduncle, and that is the aqueduct of Sylvius. So there is nothing else beyond that. And if I have to see a brain at this stage, I would see the midline, I would see a little bit of the frontal horns there. So what has happened here is simply the cerebrum is missing. The cerebral hemispheres are missing. And if you don't believe me, I will play a clip and show you that as I go across the volume, you will find no cerebrum there, but you will find the thalamus, you'll find the brainstem, the midbrain, and the aqueduct of Sylvius. So what is missing is telencephalon. The structures which come out of the telencephalon are simply missing. This is a case study at around 12 weeks, but telencephalon missing doesn't wait for 12 weeks. It has already occurred at 40th day. The telencephalon should have cleaved and it should have formed two telencephalic secondary vesicles, which did not form, and therefore this baby has a telencephaly, which now at 12 weeks manifests as absent cerebral hemispheres. And when you look at the face, you will see that there are two orbits, but they are extremely, extremely close by. This is all at 12 weeks, and therefore you know that this is a lethal anomaly, an extremely, extremely rare anomaly. And again, I have to emphasize saying that the fox is absent, the butterfly sign is absent. That is what really is the cornerstone of intracranial imaging at 12 weeks, right? So that's a telencephaly. Now we move on to the issue of cleavage. Now, if the prosencephalon doesn't cleave, what would happen? That means the prosencephalon to start with is one vesicle, then it cleaves, the telencephalon cleaves and forms as two telencephalic vesicles, and you have a midline diencephalon which is sitting there. So if the whole prosencephalon doesn't undergo this cleaving process, you have what is known as holoprosencephaly, right? And now holoprosencephaly, what controls the cleavage is induction from the precaudal mesenchyme. When the precaudal mesenchyme causes induction, it causes induction of the prosencephalon to cleave, and also the neural crest cells migrate into the frontonasal process of the face, allowing the face to form orderly. You have the frontonasal, you have the maxillary, and you have the medial nasal, the lateral nasal processes, which all come together to form the face. So when the precaudal mesoderm, the induction fails, you have holoprosencephaly, that is failure of cleavage of the brain, as well as midline abnormalities of the face. And that is why the holoprosencephaly, especially the A-lobar variant, is so very, very often associated with midline defects of the face, right? Okay, so this is a first trimester example, again, telling you that there is no, you can see the choroid plexus, but whatever I do, I'm not able to see the fox at all. And instead, I'm having the lateral ventricles going across the midline here. And you see the orbits are placed a little far away, hypertelorism. When I come to a little caudal plane at around 12 weeks, you find that there's a huge cleft, which is bang midline, and that's the median cleft lip. And the cleft lip, you can see the two halves of the lip here, and the cleft goes right inside into the palate as well. And this is the 3D rendering on maximum mode, showing you a very narrow metopic suture and premature ossification of the frontal bones as early as 12 to 13 weeks. So for some reason, the metopic suture is narrow because of a hyper or a accelerated ossification of the frontal bones. Now, in the second trimester, classically, you have the primitive monoventricle, the hippocampal edges there, and then the huge dorsal cyst which comes out, pushing the rest of the cortex anteriorly, giving rise to the classical cup-shaped cortex that you see over here. That is axial and multiplanar. As Chinmayi told us, any abnormality, you've got to go multiplanar. You've got to leave your basic views. You've got to come on to the extended or detailed fetal, targeted fetal neurosonography. And this is the coronal, showing you the thalami which have not cleaved. Mind you, I'm not using the word fused. Fused means that they had cleaved and then they came together because they loved each other. No, it doesn't happen like that. The diencephalon simply never cleaved. That cleavage never occurred. That is why it is holoprosencephaly. And that is why the two thalami are together and it's non-cleaved. The primitive ventricle is draped across the non-cleaved thalamus there. That's the primitive ventricle. That's the cerebral cortex that you see here. Hypothyroidism, midline cleft, arrhynia, and 3D, bringing it all together in one picture. So that's a classical alobar holoprosencephaly. From there, we move on to the next theater. So we finished some abnormalities which you can pick up as early as the first trimester. Now we move to the second window, and this is the second trimester. That is the timeline for the mid-trimester anomaly scan. Now, the first thing that we need to recognize here is the corpus callosum and the septum pellucidum. They have a common prosencephalic origin as far as embryology goes, and it's a late event in cerebral ontogenesis. That means the primitive forms of life, the reptilian forms of life, do not have a corpus callosum. It is only placental mammals. Not even the avians, not even the birds. It's only the placental mammals which have the corpus callosum, a great information highway between the two hemispheres. Now, whenever something comes late in evolution, late in phylogeny, you will also have it late in embryology. Simple. Ontogeny reflects the phylogeny. So therefore, we realize today by our ultrasound, by our fetal medicine, by our fetal imaging, that the septum pellucidum and the corpus callosum form only at 20 weeks. Their formation is complete only by 20 weeks. It may start by 14 weeks, but it completes only by 20 weeks. It starts forming at the anterior body region and then slowly propagates posteriorly and anteriorly. So the last portions to form really are the splenium on one hand and the rostrum on the other hand, and it is complete by around 20 weeks of gestational age, right? So it starts off there and then it goes in either direction, right? So as I said, the last segments are rostrum and splenium, a total failure. What happens if this the highway is not formed? The corpus callosum never forms. Total failure of formation results in complete agenesis of corpus callosum, and partial failure results in partial agenesis of corpus callosum. Now, in partial callosal agenesis, which are the segments to be missed? The segments to be missed naturally would be the last segments, the splenium and the rostrum of the corpus callosum, except under circumstances where there's a disruption. An ischemic disruption can cause the body to go away. An ischemic disruption occurring after complete embryogenesis, after the whole thing is formed. If there's an ischemic insult, an infective insult, you can have any part which can go amiss. But if it's embryologically missing, generally it is the splenium and the rostrum. So that is one lesson that we learn from embryology, right? Now here is our examples. That is a transvaginal scan, and you see an exquisite corpus callosum happening here. All the segments are seen. Now here is a complete agenesis of corpus callosum. I'm doing the same mid-sagittal section, but I failed to pick up a good corpus callosum, nothing of it is seen. Instead, I get an interhemispheric cyst which comes in and goes, and you have all the sulci which are radiating, or the sunburst appearance. And this is seen because this is a late study, 31 weeks. The classical gyral pattern, radiating gyral pattern, remember, is a third trimester finding. We'll never get it in the second trimester, right? So that is a complete agenesis of corpus callosum. And here you have a case of partial agenesis. You find that there's only a piece, a body and a little bit towards the isthmus of the corpus callosum that is there. You don't see the splenium. It should overhang the tectal plate of the midbrain. This is the diencephalon. This is the midbrain. It should come up to that level. It should overhang. Splenium is missing. And if you look carefully, the rostrum is also missing. So a classical partial agenesis of corpus callosum. And again, I have chosen to show you a 32 weeks case because I can show you the abnormal gyral anatomy. Now, because the corpus callosum is present, you have the cingulate sulcus which comes up. The cingulate sulcus is present. Because the corpus callosum stops here, the cingulate sulcus also stops there. And beyond which you have the radiating pattern of the gyri and the sulci. You don't have the radiating pattern here because the corpus callosum is present over here. Similarly, if I do a color Doppler, the pericallosal artery will just stop there and then it will wander off. It will never go back. The whole sweep will never be complete. So that is partial agenesis. And of course, you have indirect signs on the axial views, which take you to the extended neurosonogram, and then you will be able to diagnose these lesions. Now, let's look at the timeline. The corpus callosum, as I said, is completely done by about 20 weeks, If you see the midline earlier, I have made a collage here. That's a 17-week small little corpus callosum there. Hardly anything at 14 weeks. 18 weeks becomes a little bigger, but never anywhere to overhang the midbrain. And at 19 weeks, again, it's much better defined, but this is the thalamus. This is the midbrain. You see the dorsal hump there. It's nowhere overhanging. And even at 20 weeks, I would say, give it another week, it will do what it has to do. And by 24 weeks, by 22 weeks, you will see that the splenium overhangs the tectal plate and it has reached its full potential. The splenium is now fully formed, and that's 32 weeks. Needless to say, it would be really seen very well. So what are the implications? The implication one is when you document, see what happens in our country is that we get our anomaly scans referred to us at 18 weeks simply because our TOP Act says 20 weeks till now, and of course 24 weeks until the act, the amendment gets notified. But since we do so many of our scans at 18 weeks, and 18 weeks is still a time when the corpus callosum is still in the process of completing its formation. The corpus, since the CSP is dependent on the corpus callosum for its own embryology, the fact that the corpus callosum is not fully formed means the fact that the CSP is not fully formed. Therefore, documenting the CSP in the second trimester at 20 weeks would be very tricky. And I'm going to take you through one case. This is 18 weeks, and I have done the scan myself. And this is from my archives, which I have taken, which of course, all of us store our images. So we are able to pull out any patient at any point of time. So when I pull out for the sake of this presentation, this is what I have stored. And this is what, in my understanding, was the CSP when I did the scan, right? But the surprise came to me when she came back for a growth scan at 31 weeks, and you find the indirect sign of the teardrop shape, the lateral ventricle, and you find that the gyri are all, we did an MRI, and of course, even on ultrasound, we could make out the fact that the corpus callosum was totally missing. And that is the time I went back and soul searched on this picture. Although I have stored something like this, but this is not the corpus CSP. We've got to be very careful. Look at the way it is asymmetric. I didn't recognize that. And also the fact that the frontal horn should be immediate lateral relationship to the CSP. A CSP is not a CSP until and unless the frontal horns or the anterior horns are immediately lateral. This is 18. Remember, at 18 weeks, these clues are extremely cryptic. You need to wait longer. And from that moment onwards, if I do an 18-week scan, I always explain to the couple concerned and ask for a repeat scan after a month. Come back after a month, 22 weeks. I want to be sure about the brain. So this is an important implication directly related to embryology. Notwithstanding that, you can and you do diagnose complete agenesis of corpus callosum at around 20-21 weeks, as this example would show you. And this is Dr. Dario Paradini's article. Before 34 weeks, the pickup rate, 24 weeks, the pickup rate is poor, but after 24 weeks, the pickup rate is much, much better. You can see the percentages in the brackets, also telling us that the signs develop a little later, and you've got to be extremely critical at 20 weeks, and at 18 weeks, 17 weeks, 16 weeks, no, not at all a possibility. Now, what is the implication number 2? The implication number 2 is, can partial agenesis of corpus callosum be diagnosed before 20 completed weeks? The answer is simply no, because the development is not over. Give the fetus a chance to express the anatomy as it has to express embryologically, right? So this is a 19+ weeks. And this couple came to me in great distress because another unit had diagnosed a partial agenesis of corpus callosum. They were in great distress, and this is the mid-sagittal section I obtained. I knew there was a good bit of the corpus callosum there. This is the midbrain. This is the thalamus. It had to grow a little more. So I told them, don't worry, it's not yet over. We will give it time, you come back. And luckily they came back to me not after 2 weeks or 3 weeks, it would have been much harder for me. They came back to me after a month or so, after 5 weeks or so, and mid-sagittal section shows you a beautiful normal corpus callosum all the way down, overhanging the midbrain out here. That is the vermis, that is the brainstem that you see here. So the implication too is, don't be in a hurry to diagnose partial callosal agenesis earlier than 20 weeks. Give the fetus enough time. Just because there's a TOP Act in our country doesn't mean embryology knows it. You must wait so that to give a fair chance to this fetus to express what it has to. Then we go on to the posterior fossa, but I will skip posterior fossa because I've finished about half an hour. It's a 40-minute slot that I've been given, so I'll skip posterior fossa. I'll just go away from it, and we will come. Dr. Praveen is doing it anyway, so therefore we will get a good coverage of it in that particular lecture. And then, of course, we go on to post 20 weeks. And when you go to post 20 weeks, you're talking of sulcation and gyration of the brain. Now, there are a lot of disorders called the malformations of cortical development, where the sulci and gyri fail to form the way they have to form. And therefore, you have clues in the mid-trimester anomaly scan, which tell you that this is a possible case of an MCD. For example, mild lateral ventriculomegaly could tip you off to do a neurosonogram, not only at 20 weeks, but you would also call back at 26 weeks to look for sulcation and gyration. And the question answered here is, why 26 weeks? Because again, you have to allow embryology and development to do their job, right? So therefore, you have to study sulci and gyri. To start with, what are the sulci that you study? You have to decide what are the sulci that you're going to study. Most often, what we do is the medial hemispheric sulci, because they are the earliest sulci. You don't want to diagnose a malformation of cortical development late in pregnancy. No, you want to do it as early as possible. So you would depend on the earlier sulci. Medial hemispheric. Next would be the convexity, and last would be the basal, right? Once you choose your sulci, you should know the anatomical location of the sulci, and what ultrasound sections will yield those pictures is also very important. And once you know the anatomy of the sulcus, you know the plane of section of ultrasound which takes you there. Then, of course, you have to know how does a sulcus appear on ultrasound given its timeline of genesis and given its timeline during which it actually forms, and at various stages, how does it look? In addition to sulci, you have a huge handle in terms of a lateral fissure or the sylvian fissure. So if you have the medial hemispheric sulci and the lateral fissures, you will be able to do the diagnosis of a malformation of cortical development as early as possible. And let's see how early is possible. Now, this is just to take you, every sulcus starts as a mere indentation. Then it deepens, the base being much more than the height. When it deepens more, the base is narrower, but the height becomes more. And finally, the sides oppose and you have an eye there, right? So it's grade 0, grade 1, grade 2, grade 3. Just remember grade 3. Grade 3 is narrow base and a taller depth. Just remember that, right? So that is what, and I have shown in pictures over here, and that's a classical grade 2, classical grade 3 that you see of the parieto-occipital. Now, why I said parieto-occipital, every sulcus has its own timeline, and this is a timeline for the parieto-occipital sulcus. Every sulcus will have its own curves, right? Now, what about the lateral fissure? Lateral fissure again starts off as a mere indentation there. Then it becomes obtuse angled as the insula sinks inside. And as it sinks more, the angle becomes right angled. And then the opercula begin to overhang, converting it to acute angle. And finally, the opercula touch each other by about 36 weeks. And again, I want you to remember 24 weeks for perpendicular and 25 to 26 weeks for acute angle. Just remember this, and that will go a long way. And you can see the acute angle, the right angle here, the acute angle here, and the obtuse angle here, as this collage tries to demonstrate. Now, you will realize that the sulci which fall into our mid-trimester period are the parietomedial, medial hemispheric, which are parieto-occipital, calcarine, and cingulate sulcus. This central sulcus is a convexity sulcus, and you will see in 75%, these sulci should and must be seen by 20, 22, 24 weeks. And that is why we choose the magic figure of 26 weeks. So the mantra to me is, if there is a lateral ventriculomegaly and I have failed to show any other problems in the mid-trimester ultrasound, I need to see this lady again. And how fast is this again? There's no point in calling her every week. I need embryology, I need development to proceed, and I will call her only at 26 weeks. What is sacrosanct at 26 weeks? Parieto-occipital fissure is grade 3. Calcarine is grade 3. Cingulate, grade 2. Convexity sulcus, 1. The central sulcus is present, and lateral fissure must be acute angled, right? So that is 26 weeks. You find here that is a nice deep parieto-occipital fissure, grade 3, and this is an acute angled lateral fissure, or parieto-occipital sulcus and lateral fissure, or the sylvian fissure, again telling you that things are going well, nothing really to worry in this particular case till now, right? Now, on the other hand, let us look at this. There's a transvaginal ultrasonogram, and I'm trying to show you the coronal pictures, the coronal sections. And in the coronal sections, I'll take you to the bookmark 1 here. This is a transcaudate section. On transcaudate section, the two frontal horns, or the anterior horns, are continuous with each other. That means what is missing? The CSP is missing, and that indeed was the finding which prompted an extended neurosonogram, right? On the axial, you see the CSP in all 3 sections, in transventricular, transthalamic, transcerebellar. You know, that is why documentation of CSP is so very important. Since I didn't see it, I went on to the neurosonogram, and you will see that there is no CSP. There is a continuation of the frontal horns on either side of the midline. But the interhemispheric fissure is well seen, and also the fact that the corpus callosum is beautifully seen. You can even see the callosal sulcus, right? Let me see what this bookmark is. When I go to this bookmark, you see the corpus callosum and you see the callosal sulcus there. So the corpus callosum is present, but the septum pellucidum is absent. The septi pellucidi is absent. And when you have this, you diagnose a condition called septal agenesis. And in septal agenesis, we need to be worried about the optic chiasma, because if the optic chiasma is small, you're going to diagnose septo-optic dysplasia. But in this case, more than the optic chiasma, you should understand that this was done at 26 weeks. And at 26 weeks, you find that the lateral fissures are shallow, obtuse, a big red flag telling us that this is delayed sulcation. Also, the fact that the cingulate sulcus is not seen. Cingulate sulcus is not seen. Cingulate sulcus is not seen in the mid-sagittal section. When I go to the transcerebellar coronal view, the calcarine is just merely an indentation. It is nowhere deep. It's nowhere close to grade 3 at all. So therefore, this is a classical lissencephaly associated with septal agenesis. Septal agenesis isolated is a benign condition, but lissencephaly is not. So there, and again, this is the parasagittal section, shows you the surface of the cerebellar hemisphere on one side, and there is no central sulcus there. So in all ways, including the parieto-occipital, this brain is telling us that there is an agiria. Okay, that is one example I choose to show, and I'll wind off this presentation with the last example. Here is a 33 weeks gestation, was sent to me because there was something wrong. The ventricles were not looking normal. And as usual, there were signs in the transaxial, but I'll take a shortcut and I'll take you through to the coronal section in this particular case. Again, a transvaginal ultrasonogram. And in the coronal section, the first thing which stares at us is that the midline of the brain is shifted. And why should the midline of the brain shift? Why the one hemisphere is small or the other hemisphere is large. Over here, you will realize that this is the left side, the left hemisphere is small and the right hemisphere is large. Now, two things can occur. Is the larger hemisphere abnormally large, or is the smaller hemisphere abnormally small? How do you answer this question? Because if the larger hemisphere is abnormally large, I'm going to diagnose hemimegalencephaly. But if the smaller hemisphere is abnormally small, I'm going to diagnose the conditions of cerebellar hemihypoplasia. So the clue to us is look for associated intracranial anomalies. Now, the first thing which stares at us is you have plenty of convexity sulci, innumerable. You can see so many of them. You can see the cingulate sulcus beautifully, the callosal sulcus. You can see the corpus callosum there. You can see a small CSP there. That's the ventricle, which not very well seen. And you even see the olfactory. You can see the olfactory sulcus. That's a basal sulcus. Compare this to the opposite hemisphere. Nothing whatsoever, no sulci whatsoever. So therefore, I would say that this is abnormally small and this is normally large. But because this is small, there is a midline shift, right? And look at the ventricle is dysmorphic. So instead of thinking of hemimegalencephaly here, I will think of conditions which result in cerebral hemihypoplasia, and a typical condition is Dyke-Davidoff-Mason syndrome or a Sturge-Weber syndrome. This is just to show you a mid-sagittal section showing you a normal corpus callosum, and this is the cingulate sulcus on the normal hemisphere side. You can see the whole cingulate sulcus beautifully seen, and this is the MRI which shows you all the findings. There is a normal hemisphere here with all the gyri sulci, including the olfactory. And this is the dysmorphic ventricle, no sulci gyri at all. Again, the same findings over here. Look at the gyration there, look at the gyration here, and look at the abnormality there. So this is a classical left cerebral hemihypoplasia. And again, what helps us is the timeline of sulcation and gyration. So you have three windows here: the neural tube defects, the open neural tube defects, the hollow prosencephaly spectrum. You can tackle it perhaps in your first trimester window, even embryologically. The corpus callosum and vermis, typically in the second trimester, 20 weeks. Sulcation, gyration, you've got to wait for at least 26 weeks, and things become more and more clearer as you go higher or forward or with advancing gestational age. So embryology aids in findings vis-a-vis the timeline, and associated findings, it tells us what to do. And it also, like in open neural tube defects, it helps us to plan our prophylactic strategies well in time. So thank you very, very much for a very patient listening. Thank you. Thank you. Over to Ashok.
Thank you, Dr. Ramamurthy. That was spectacular as usual. And thank you for continuing to teach us, to inspire us, and to always make things so simple that we are all of us all set to go ahead and try this out in the coming week. We always thought embryology was terribly boring, and thank you for making it so clinical for us. Thank you indeed. May you always be associated with us and help us out whenever we have a problem with these. Thanks so much. We move on to our third speaker. We have Dr. Indrani Suresh, who again requires no introduction. For those of you who are new to the world of fetal medicine, you should know that she is truly the grandmother of fetal cardiac ultrasound in this country. She had pioneered techniques. She has taught us step by step, held our hand, and told us that yes, look at the fetal heart. There is a fetal thorax, and inside the fetal heart, inside the fetal thorax, there is a fetal heart. And she's brought us from there to where we are today. Thank you, Dr. Indrani, for always being there for us. I look forward to your talk on the evaluation of the cavum septum pellucidum in the mid-trimester scan. Over to you to share your screen.
Good morning. Now I will share my screen. Is my screen visible?
Not as yet. Was your presentation open?
Yes, my presentation is open.
And we go to the second set where we just open the presentation, not the whole desktop. Maybe you can stop sharing and re-share.
Could you just tell me what do I do now? Share?
Well, first unshare, and then
will.
You stop your share.
Now?
Perfect, wonderful. Now we just have to go to full screen.
Yes. Now I'm in full screen.
Not yet. You have to go to the bottom left, yes.
Yes.
And click on the third icon there. That's marvelous. Now we can see you, and we can see your slides, and we can hear you. And the pointer is pointing beautifully.
Okay. What do they say? Good morning, good afternoon, good evening. You are told, thank you very much for the kind words of introduction, Dr. Ashok. I'm trying to be young by being associated with people like you, Ramurthy, Chinmay, and thank you very much, because this talk has really stimulated me, because over a period of this past 2-3 months, I have not been doing a lot of webinars, and I thought I have slowed down. Let me, you just have to tell me where I stand at the end of the lecture. So already the start has been done very well with Dr. Chinmay, and I suppose I should quickly move on to those slides which I'm going to talk on the guidelines and all that. So we move on as cavum septum pellucidum, which is usually a rectangular box. Sometimes it can be triangular. And I would like you to mark the word, it's a marker for normal central forebrain development. And it should be always seen in target scan. As Dr. Ramurthy has said, how important it is to make sure the shape, size, everything looks optimum by eyeballing. And we have our 2007 guidelines, and it has been updated in this 2020 by Palladini and others, where they have added on more point on must do and all that. So this is the plane of ventricle where we have to see this anechoic rectangular box. I also encourage people to read on the article on this anterior echo-complex and posterior echo-complex. That's again a 2013 or 14 article. It's a beautiful one, which makes us look at more points in the anterior aspect and in the posterior aspect. So this CSP is one of the main things when you are trying to look at the anterior echo-complex, where you have the fox, interhemispheric fissure, the chilosum, and the two frontal horns, and the rectangular box. Okay, the plan of the lecture would be, I'll be quickly talking on the development and the ultrasound appearance and pitfalls, and abnormal appearance of cavum septum pellucidum, and analysis in the Mediscan we did for about 12 years. I just looked into my data, and we will sum up what would be the best carry home points. As we had seen, the development has been discussed. I just would like to say the lamina terminalis is the one from where the corpus callosum develops, and there is a cavitation of this commissural place in the anterior aspect, and there is fluid-filled CSF with two leaflets of septum pellucidum. And it should be always imaged from 18 to 37 weeks. And the best thing would be to looking at your BPD of 44 to 88. And of course, it starts closing from posterior to anterior from 24 weeks onwards. There would be times when we are looking at the growth scan, we would see a narrow CSP. And what would be the anatomy and function? Like this is the lamina terminalis from where these commissural fibers form, and it forms as a central relay station between the diencephalon and the limbic system. That's why sometimes when you have abnormalities of cavum septum pellucidum, it has been quoted, it could lead to some psychotic disorders. So looking at the anatomical, one moment. Looking at the anatomical relationship, we are looking at the cavum septum pellucidum. You have the anterior and the roof, you have the genu of the corpus callosum, and you have the rostrum, and there is your commissure, cornix. Cornix is commissure, and posteriorly cavum septum pellucidum continues as cavum vergae. So as you would see, the word I would like everyone to remember is, in this corona pandemic, remember coronal, because this is one beautiful sentence I picked up from Rabi Choi's one of the lectures. So remember our coronal sections, which are very, very important. Where you would see here, that's the anterior coronal section where you are seeing the two frontal horns, and you have the corpus callosum there, and you have your cavum septum pellucidum as illustrated in this anatomical picture. What is happening is, from here on, it goes as cavum vergae. That's a point of the foramen Monro. You don't have to worry about it. So if you see here, from here to here, it will be vergae. Okay. So what are the things which would mimic a CSP? If you're going to have, why it is always said you have to see it in the ventricular plane, it is always seen as a rectangular box, or sometimes it will be seen as a triangular structure. But then when you go down, you find in the transthalamic plane, you can see these two little ones, cornix, which can mimic your CSP. Many a times we just look back on the missed cases and the previous reports and all that, you would see this fornix has been labeled as CSP. So remember, here these are 2 lines with anechoic area. Here it is 3 lines. Other thing that can mimic the CSP is the pulled up third ventricle. This again has been wrongly labeled as, but you see, this is the rectangular is just lying horizontal like this. Here it is vertical rectangle. This is not acceptable. So there are normograms for CSP. more and more people are looking at it. Many times in our own center, internal referrals will come as narrow CSP or wide CSP. It's good practice. The people have started looking into it and started also measuring it. So what are the conditions in which you will have pathology of septal leaf abnormality? As we said, it would be a start point for abnormalities of prosencephalon. So whenever you have agenesis of corpus callosum, septo-optic dysplasia, lobar holoprosencephaly, hydran and porencephaly, schizencephaly, these are the conditions in which you will have absent CSP. And also it can get destroyed because of the hydrocephalus at a later date. Very rarely it can also be isolated. Before you say it is isolated, you must make sure you do your complete workup. So now let us take some common examples. As we said here, the septal leaflets are there, but then it looks narrow. And narrow CSP does with, when you do an extended neurosonography, everything is all right. As you see here, you find a very well illustrated corpus callosum, midline structures were normal, posterior fossa structures were normal. So this narrow CSP has got the isolated narrow CSP has a favorable outcome. Now let us look into CSP which size is wide. Then you start measuring. If it is more than 2 standard deviation, it is very important because whenever you have a wide CSP, it is not like narrow CSP. You have to be very careful. You have to look for associated anomalies, especially that could be also a pointer for trisomy 18, which I will be showing in my database when I just analyze. So when you have enlarged cavum septum pellucidum, you have to look for associated abnormalities. If there are no associated either intracranial or extracranial anomalies, they tend to have a favorable outcome. But you have to do a growth scan. You have to be very watchful. So now we looked at the narrow and wide. Now we will look into when you have an absent CSP. So in the axial scan, as you would find, we are not seeing these 2 lines of the septal leaflets. So we are moving over to our coronal scan, and then again in the coronal scan also we are not seeing the septum pellucidum. When we do a dedicated ultrasound, if we are able to get satisfactory information, like you are doing an endovaginal with high resolution and you get best information, MRI also gives similar information. There is not much of additional information. But whenever you have poor penetration, visibility is good, not okay, then we definitely have to resort to MRI even in your target scan. As you would see here, this is a case where we thought it is absent CSP, but then the visibility was not good. We could not get endovaginal sections. So when we referred to MRI, they called it as a narrow CSP. So when we have absent CSP and you have a picture, what you are seeing here now, like you have a fused frontal horn, then we need to remember our differential diagnosis of lobar holoprosencephaly. This is a picture I just took from Ishwak, and then I will show a couple of cases subsequently so that audience can look into it and try to come to a conclusion. So in both conditions, there is fusion of the frontal horns. But then look here, in lobar holoprosencephaly, the frontal horn is not well developed, but here the frontal horns are developed well. And also when you're doing a coronal section, you find fused frontal lobes. And whereas here, the frontal lobes are separate by the intrahemispheric fissure, and you're seeing the frontal horns. Because when you have a simple septal agenesis, it has a very good outcome. Now let us look into a case. So you have a fused frontal horn. So we are going and doing a coronal. This also shows fused. But then what? No, the frontal horns are not developed well. And when you do anterior coronal, that's orbital roof, and you can see the 2 frontal lobes, you're not seeing the interhemispheric fissure completely. You find there is fusion. So the diagnosis is lobar holoprosencephaly. We will go into the next illustration of again a fused frontal horn and seen in axial and in coronal section. But we move our probe towards the orbit. You can see here the well-developed frontal lobes and the frontal horn and the interhemispheric fissure. And still more anterior you go, you find a beautiful interhemispheric fissure and the 2 well-developed frontal lobes. So that gives us a diagnosis of septal agenesis. So this is how we have to work up. So the key point is your frontal lobe and the frontal horn. So whenever you have a septal agenesis, the question asked is this baby is going to have a isolated one or is a part of septo-optic dysplasia? So what we try to look at is, this was one of the landmark papers which came as the optic chiasma can be seen and you can measure. This optic chiasma can be obtained both in the axial when you go to the base of the skull and in the coronal. But only thing is, at the end of the thing, many times, even if the optic chiasma is there, the optic nerves may not be developed well, and the endocrine problems or pituitary abnormalities we will not be able to see prenatally, whatever test you're going to do. So this is a good article which came in March 2020, where they had looked at the long-term postnatal outcome of fetuses with prenatally suspected septo-optic dysplasia. So what they had looked at is, so that they would see all these babies postnatally and then find out about the visual endocrine to differentiate whether it is an isolated septal agenesis or a part of septo-optic dysplasia. So if you look in their cases of 214 cases, they had looked at for about a 10-year period, the retrospective study it was. They found 18 cases were looking at isolated septal agenesis, of which 12 were live born. Of this, 5 of them turned out to be having a septo-optic dysplasia, of which of these 5, 2 of them had some features in the prenatal MRI as microphthalmia, optic nerve hypoplasia, whereas 3 of them did not have any imaging features either in the prenatal or postnatal, and only on working up the fundoscopic examination and endocrine workup, it was concluded. So to say, when you have even isolated septal agenesis, about 20-25% of them can have septo-optic dysplasia, which can be confirmed only by postnatal evaluation. This we have to make it a point when we are counseling the patient. So from absent CSP, we will go on to the abnormal shape of the CSP. Look at the CSP in this picture. You have a rectangular box. Whereas on this side, if you find, this CSP looks small and it looks also short. What do I mean by saying short? When we do the measurement, that is the CSP length and that is the CSP width. When we look at it here in this picture, it is a short CSP. There came the analysis of CSP ratio, which could be a marker for partial agenesis of corpus callosum. So whenever you have a shorter CSP, all these triangle ones, and a wider CSP, and the ratio becomes less than 1.5, that could be a marker for 16 or 20 cases of partial ACC. They found the CSP ratio was less than 1.5, abnormal shape, and also the CSP ratio, which was a hallmark. So this also again, which should make us look carefully with extended ultrasound and also do an MRI few weeks later, like 24 weeks, so that we would be able to get optimum information. Now we go on to the question of absent CSP, which is a most important surrogate marker for agenesis of corpus callosum. So as we said, from 44 millimeter to 88 millimeter, we should see the CSP. Here is a fetus with a BPD of 45 millimeter, 18.5 weeks. And you look carefully, you find the midline fox is not interrupted. And then you can see the teardrop shaped ventricle and the frontal horn are far away from the midline. You can see multiple lines instead of this central line being interrupted by the CSP. So we move our transducer to coronal plane. Again, you find widely separated frontal horn and absence of corpus callosum and CSP. So this is very, very useful that we need to said, as Ramurthy said, we need to document, magnify the image, The whole thing is from the time we started looking at the NT, the buzzword magnify has got into our system when we are doing imaging. Of course, you do not have the pericallosal artery. Instead, the anterior callosal artery is going straight like that. I mean, anterior cerebral artery is going straight like that. When we do a 20-week scan, when you do a good extended neurosonogram, endovaginal, also we get equivalent information as we get in MRI. So that's a picture of a complete agenus of corpus callosum in a 20-week fetus. You can see this fetus does not have any sulcites bald. So as pregnancy advances, there would be times when we find this posterior horn is little more dilated, and that would be a strong pointer. Here you could see it's a 23.5 weeks, and you find this staring ventricle because the ventricle acts as a contrast resolution and triggers us to look in for more in-depth evaluation. And you find here it is not a global ventriculomegaly. Whenever you look at a ventriculomegaly, you must see whether it's global or focal. Here it is focal, occipital horn, and the frontal horn is away. And you find this 3 line in the midline. And of course, you have the mid-sagittal section showing absence of corpus callosum. And we know we have to look carefully for extra CNS anomalies and also CNS anomalies, cardiovascular system anomalies. It can be associated, ACC can be associated with a lot of chromosomal abnormalities and single gene, many Mendelian syndromes. And the prognosis, even when you have an isolated non-syndromic lecture, I'm sorry. So even you have an isolated non-syndromic ACC, it could be associated with borderline intellectual impairment, and also very important at the school going age and adolescence, they would have some issues on coordination and things like that. So it is important, even when you have an isolated ACC, you should do postnatal follow-up and then put them into neurodevelopmental protocols and then do early stimulation so that you can take those children under the right path, which would be good for them to achieve the best. So other problems of CSP like thin CSP, thin corpus callosum, thick corpus callosum, and lipoma of the corpus callosum, it could be a pointer when we are looking at abnormalities of CSP. So the CSP also could be absent when there is a ventriculomegaly, as you find here. There is a gross ventriculomegaly, you have absent CSP because of the disruption. I would like you to note the point here, the whole ventricle is dilated. In both sections, axial and coronal, you have absent CSP. So here is a case where you have absent CSP, but then you have bilateral clefting disorder of the brain here. The cleft is reaching up to the surface of the brain. And MRI also confirmed this condition as a bilateral wide open lip scissioncephaly. Whereas you see this particular case where the CSP is not clear. On the coronal section, you find the lateral ventricle, there is a cleft and going up to the periphery. These are the ones which would be sometimes technically very challenging because you will have a lot of artifacts like from the reverberation artifact from the skull, which should mask this and it could miss. But then the point is when you find absent CSP or irregular CSP, you have to do dedicated extended neurosonography. You have to do TAS and TVS, and still you are not able to achieve. You have to wait for a couple of weeks, like 22, 24 weeks, and then make sure to fix the etiology. This, of course, I had picked up from the show. Here is another example where there is an absent CSP, there is ventricles are asymmetric, and then one side is more dilated, and the MRI proved it to be a porencephalic cyst, as you see here. The ventricle is communicating with the brain parenchyma. It was a thin brain parenchyma over there with a destructive process. So here I would end up with slide last case, which is very interesting. At 32 weeks, she was advanced maternal age, precious pregnancy, referred as dilated third ventricle at 32 weeks of gestation. And then when we did extended neurosonography, we could find the corpus callosum. And still the CSP was not imaged, and we thought it could be a partial ACC with some interhemispheric cyst. But then the good news came from MRI, where this, after doing these are the coronal slices and the sagittal slice, where you could see here the corpus callosum and the cingulate sulcus going all the way. And then they said it is a cyst in the cavum septum pellucidum and vergae, which is just distending. This baby had a favorable outcome. This is where sometimes we may need to do an MRI in the later weeks of gestation, even if we're finding out absent CSP and callosal midline abnormality. It would be worthwhile looking at the value add of the MRI in later gestation. Now I'll look into the data we studied for about 12 years. We found there were absent CSP in 557 cases. So it is one of the most important ones of the CNS abnormalities, 7,479. 7% of them were showing a absent CSP. Looking at the distribution of absent CSP, the whole green thing, 389, that is 70% of them were cases of complete agenesis of corpus callosum. Then came the prominent CSP, about 21, narrow CSP. As I said, narrow CSP, we are seeing quite a few when we have started looking at the CSP very carefully. But these narrow CSP, when they were isolated, they had a good outcome. And then prominent CSP and isolated absent CSP. But unfortunately, all this 31, we could not get a follow-up. And abnormal CSP shape in partial ACC. So I would like you to look at the next one. So we divided it into two groups, 2007 to 13 and 14 to 19. In spite of all these guidelines and all that, still in the later gestation, we were seeing a good number of cases where the CSP has not been looked into very carefully in the target scan. And also in this particular bar, when you have these blue ones are all denoting associated anomalies. When you have absent CSP, associated anomalies were quite high. When you have narrow CSP, associated anomalies were less. And when you have a prominent CSP, again, associated anomalies were high. This is where I said, when I looked into this data of prominent CSP, we picked up about 7-8 cases of 18 trisomy, because sometimes it's 18 trisomy in target scan, you may not be able to pick up all, or they may not be showing. The growth restriction comes in the growth scan. 18 trisomy, you can have also high resistance uterine circulation. You may tend to overcall it as placental dysfunction. And when you go on to the growth scan, you find more evident features. So when you have a white CSP, look for cranial and extracranial anomalies carefully and do a meticulous growth scan at 28 weeks of gestation. So putting everything together, I just put this in red alert. Be aware or beware of the CSP and suspect abnormal CSP in axial scan in the ventricular plane, because that's a plane where you have the widest of the CSP. And when you have anything suspicion, or even other ways, this extended neurosonogram, no, when we are doing with high frequency probes, and if the lady's penetration is good, even in routine target scan, you could extend your examination to doing some coronal clips and sagittal clips you can just take and store. And at a later date, you can sit and analyze them. So you are used to doing this, what I tell my colleagues as, like Chinmayi was telling, I say our hand 3D is an excellent tool, which we can do either in target scan or in growth scan, PA or TV. Find out an area where the abdominal wall is thinnest so that you can send your sound waves. There are many times nice profile baby will be showing. So you will be getting an access to the anterior fontanelle. So you could practice that with your hands. Don't sometimes when you do endovaginal and your probe is inside the vagina, I encourage again do 3D clips so that at a later date you can analyze them and then you can. So these 3D and stored volume and the clips helps us to understand the brain much better, and it comes by practice. And whenever you have any problems of CSP, it has to be followed up with MRI, and we have to plan genetic testing depending upon what we are looking. The biggest limitation is a case of isolated septal agenesis. We will not be able to say whether this baby is going to present postnatally with any optic nerve problem, optic asthma problem, or retinal problem, or endocrine problem, at least in about 20-25% of the cases. So you have to put it across to the patient in a gentle manner, but then make sure you also do a postnatal follow-up on these patients. And depending upon whether they're terminated, do an autopsy study. If they are live born, we could take from the stored DNA, advanced genetic testing. It is very important. All these, many times we come across agenesis of corpus callosum in growth scan. It is important that we have to encourage them to come for follow-up developmental assessment so that we can give them the right path in school and in achievements, because sometimes when they are put in high academic schools, they are not able to achieve. The children are being threatened with the parents, because we did a large group of 15-year follow-up on this agenesis of corpus callosum. We found some of those children are fairly bright. Their arts and music, all that comes, whereas mathematics they are not able to do. So you must not be putting them to the task which they are not able to do because of their disability. So it is important that we need to support these kids after birth as well and help the families. Thank you very much.
Thank you, Dr. Indrani. That was absolutely marvelous as always. And I do hope one of these days we're going to get a chance to hear from you how you handle your archiving and your statistics and how you put all of this together, and you can draw out your own statistics after all these years. It's something we truly must learn from you. Thank you for that marvelous lecture. I think our faculty has held so much everybody to their screens that we haven't had too many questions in the question box, but I will take this opportunity to ask the 4 or 5 questions we have here. And the first question is for Dr. Chinmay, and Seema Yadagiri wants to know whether a lemon shape can be possible for the skull without a spinal deformity.
Sometimes it may be a physiological condition. So first and foremost, when you see anything that is out of the ordinary, it is imperative that we check the spine very, very well. And the lemon shape comes only after there is a distortion in the balance of the spinal fluid. So if there is no obvious protrusion, no change in the posterior fossa, then we can consider it as a normal variation.
Thank you. And the next question is for Dr. Ramamurthy. Why is the cavum septi pellucidum cystic? You have to unmute yourself, Dr. Ramamurthy.
Yes. Now, it is cystic because the septum pellucidum itself is made up of 2 membranes. That is why we call it septi pellucidum. It's not septum pellucidum, but because there are 2 membranes, in the fetus, there is a cavum, there is a fluid collection which separates these 2 leaflets. And that is why it is called cavum septum pellucidum. And the cavum septum pellucidum actually by about 37 weeks disappears. The fluid goes away, but the septum pellucidum is still there. Now, the septum pellucidum fluid or the CSP fluid is not CSF. That is, it was being called the 5th ventricle once upon a time, but it does not, the fluid content is not CSF. Therefore, it is not a part of the ventricular system. So it is just that in the fetus, the 2 leaves are separated by fluid, and towards term, they come together, and that is what continues in later life, in the pediatric and in the adult life. You only have a septum pellucidum.
Thank you. And we have 2 questions for Dr. Indrani, and both are on the aspect of the prominent cavum septum pellucidum. Somebody wants to know whether the evaluation is subjective or objective, and how we should handle that, and also the genetic evaluation of the absence of the prominent cavum septum pellucidum.
So when you have a prominent septum pellucidum, first is subjective. Again, when anything that is subjective, you have to make it objective. And then see at what standard deviation, because the 2SD cutoff is reasonable, because the 2SD will be about 1.5 centile like. When you have a picture like that, as I said, it is important that you go and do extended neuro examination and extended examination of the fetus, because you can have a wide CSP and you can have, we have had cases where it is a part of a musculoskeletal problem. It has been a part of trisomy 18. So when you have done a thorough examination and nothing is there, then you can reassure them.
Thank you. And another question, which is the presence of a cavum vergi normal?
Normal.
Yes, yes. Cavum vergi is normal. Beyond 24 weeks, it will become smaller and smaller. Because this whole thing now starts closing from posterior to anterior. The first thing that closes is the cavum vergi. You will find CSP and cavum vergi. Cavum vergi is nothing but posterior extension of the cavum septum pellucidum. You will find them at 20-week scan.
Yeah.
By about 24 weeks, it starts slowly closing. Some fetuses, they tend to have prominent cavum vergi also, even in later weeks of gestation. This finding we see whenever we have this extreme preterm babies, 26-weeker, 28-weekers, which is normal.
Yes, the other question is, can we have a complete agenesis of the corpus callosum without colpocephaly?
Yes, you can have complete ACC without colpocephaly. Because if you take the cutoff of 10 millimeter, especially when we are doing target scan, the size of the ventricle may be just 8 millimeter, sometimes 8.5 millimeter. These are the cases, no, they get missed in target scan. Because when you have a dilatation, that catches your eyes, because ultrasound, no, solid fluid interface, you would be able to get that alert. So actually, when we looked into our group of cases where not seen in target and then picked up in growth scan, because from various places we get referred, and if they have a good picture on target scan, I tend to copy it and then measure the ventricle size. A good number of them they don't have really staring ventricle. That's how whenever you have a staring occipital horn, that people refer immediately, even if they don't want to do extended examination. It could happen. We also analyze cases, a group where with dilatation of occipital horn, without dilatation of the occipital horn, whether there is any difference in the developmental assessment. Because the we found even with dilatation of 1.5, 1.7 centimeter, 17 millimeter, the children were having a good developmental outcome. Whereas with hardly 11 millimeter also, they were having disability. So this dilatation does not, it's not a pointer to say this baby is going to have developmental issue or not.
Thank you. And we also have the privilege today of one of the living legends of ultrasound, fetal ultrasound, being in our presence on this webinar, Moshe Bronstein, who has such a huge fan following, if I may call it that, in India, is here with us on this webinar. We didn't know he was going to be here. But the other piece of good news is that he has very kindly agreed to address us in the near future. And I look forward to that presentation. And he has added that, of course, the cavum septi pellucidum is not always cystic and can be occluded with a completely normal outcome. Thank you, Moshe, for being here with us, and we look forward to having you as faculty soon. There are a couple of questions that have come in the last few minutes, and one of these is the importance of a cavum belli interposity cyst. Should it be reported at all? Dr. Ramamurthy?
Yeah, cavum belli interposity cyst is a cyst. Cavum belli interposity is a normal anatomical space below the splenium of the corpus callosum and above the internal cerebral vein. It's a normal space. The problem is if it becomes prominent, if there's a cyst sitting there, we will begin to see it as an interparietal cyst in the interhemispheric fissure. Now, the proper way to go about this is to do a mid-sagittal section and show that the cyst is under the splenium and above the internal cerebral vein. If it's below the internal cerebral vein, it becomes the quadrigeminal cistern cyst. It should be above the internal cerebral vein. So once it's a cyst there and it's sitting over, I am not really worried. I just measure the cyst because it's most often it's a small arachnoid cyst happening there, or it is simply just a prominent space. It's not supposed to be prominent, it is prominent. However, if there is a spina, open spina bifida, and if we wait till the second trimester, some signs develop in the second trimester, and one of them is a diamond-shaped cavum veli interpositi, which comes in. So for some reason, the veli interpositi, the cavum veli interpositi becomes prominent and assumes the shape of a diamond on an axial section. So I call it the diamond sign, but it's well documented and well described both MRI, ultrasound wise, and that perhaps is the lone pathological cause. Otherwise, a small cyst there. Once you know it is below the splenium, the corpus callosum is normal, not doing anything, just leave them alone. Nothing really to worry.
Thank you. We will move on to a 3-minute break with our trade partners. If Sumit can put on their videos, please. And we will be back in 3 minutes with our last 2 presentations.
Thank you.
Ashok. I will say goodbye.
Thank you, Dr. Nilani. Very kind of you.
Thank you, Preeti, and all those Odisha chapter, sonologists, SFM, all of them.
Thank you.
See you everybody. Bye-bye. Bye.
Bye-bye. And the attendees will wait for excitement. And if we can have a video from GE as well. There are a few more slides from LifeCell.
அப்ப நீ கால் பண்ணும்போது அந்த லெக்சர் கொடுத்துருந்தீங்க. ஆமா, அதனால டகடகன்னு அது போன சின்னது பண்ணீங்க. இங்க இங்க Thank you, Sumit. And we move on to our next talk. And our next speaker is
Dr. Rachita Ramamurthy, and people love to refer to her as Dr. Ramamurthy's daughter, and I like to refer to her as truly a legend of tomorrow. She has proved in a very, very short span of time that she is an excellent speaker, a wonderful researcher, and a great teacher as well. Congratulations for achieving this so fast, Rachita. I really look forward to your talk on the approach to lateral ventriculomegaly.
Thank you so much, sir, for those wonderfully kind words. I'm blessed to have your encouragement, and I would like to thank the entire team SFM, especially Oriya chapter, Dr. Hasmukh, Dr. Preeti, for inviting me to take part in this scientific session. It's indeed a pleasure and a privilege. Thank you so much. It's always very, very difficult to follow a legend like Dr. Indrani, but I think I'll try my best. And let's move on to the lateral ventricles now. I'll start sharing my screen. Is my screen visible?
Yes, and we need a full screen.
Yep, and the marker.
Marvelous, and the pointer is there, and you are there, and your voice is there. Thank you.
Good evening, everybody. We've had wonderful sessions about the basic approach to imaging of the fetal head by Dr. Chinmayi, and then we saw how important the embryology is to determine if the head is normal or abnormal. And then Dr. Indrani has taken us through the importance of the CSP. And the next landmark that we must study in every single fetus throughout gestation is the lateral ventricles, or the ventricles of the fetal brain. So let's come to what the ventricles are. The ventricular system in the human brain comprises of 4 ventricles, and that is of 2 lateral ventricles, 1/3 ventricle, and 1/4 ventricle. So these 4 ventricles make up the ventricular system, and we know that the CSF, the cerebrospinal fluid, circulates in these ventricles and goes out through the foramens into the subarachnoid space and into the spinal canal and dural space. So these 4 ventricles are very important, and they change their dynamic structures, and they change according to the development of the brain around. So the term ventriculomegaly is used for any dilatation of these ventricles, and colloquially, most commonly, it is used for the dilatation of the 2 lateral ventricles. So anytime we see the term ventriculomegaly, we should think of the dilatation of the 2 lateral ventricles. So coming to the imaging of the lateral ventricles, how are the lateral ventricles oriented? The 2 lateral ventricles are oriented in an antero-posterior direction in each of the cerebral hemispheres. We have the right hemisphere with the right lateral ventricle and the left hemisphere with the left lateral ventricle, and they're oriented antero-posteriorly with horns and a body and an atrium. There are 3 horns: the anterior or frontal horn, the posterior or the occipital horn, the lateral or the temporal horn, and they all meet at the body, and where the body and the posterior horn meet is called the atrium of the lateral ventricle. So this is the entire structure of the lateral ventricle, and this ventricle can, of course, be seen in all 3 planes: axial, parasagittal, and coronal sections. In the axial plane, you see both the ventricles. In the parasag, you cut through either one of the ventricles, and in the coronal sections, you again see both the ventricles. You can also use 3D multiplanar imaging to image the lateral ventricular system. So let's come first to the standard plane of imaging. That's the axial transventricular section. Dr. Chinmayi already showed us that in our day-to-day examination of every fetus, especially in the mid-trimester, we have to do the 3 standard axial planes. And the 3 standard axial planes are the axial transthalamic, axial transventricular, and the axial transcerebellar planes. The second plane, the axial transventricular section, is what we use to study the 2 lateral ventricles. So this plane is through the CSP and part of the thalamus and through the posterior horns of the lateral ventricles. So you have the anterior horns, the CSP, which forms the anterior complex that we just saw, and then the body and the posterior horn. So the entire axial section of the lateral ventricle is covered in this axial transventricular section. in a routine axial transventricular section, when we put the midline horizontal, that is how we take the standard plane. When we put the midline horizontal, we notice that the far ventricle is very nicely, easily seen. But the near ventricle and the near hemisphere is always hidden in reverberation by the calvarium. So this is a problem for us to image the ventricle and the cerebral hemisphere on the near side. So what we can do to look at the near hemisphere is to do a little maneuver of the probe, and I'll show you how to do the maneuver. You take the probe instead of from the midline of the skull, move it to the posterior side of the fetal head. And in this maneuver, you put the beam through the lambdoid sulcus, through the lambdoid suture. So because the beam is passing through the lambdoid suture, the near hemisphere and the near ventricle is better seen, better imaged. And then you get this picture where you see the two walls, the medial wall and the lateral wall of the ventricle very, very well visualized. So by this maneuver, instead of the midline being horizontal, we are now making the midline about 30 to 45 degrees to the horizontal. This is a simple, easy maneuver that all of us should practice, and we should do it in every single study because it is compulsory, it is mandatory to visualize both the lateral ventricles in every single fetus. So that's how we do it. And why is it so important? Just because we're seeing the far ventricle well and we've measured it and it's about 5.5 millimeters here, doesn't mean we can assume that the near ventricle is normal. In this fetus, for example, after I did the maneuver, I saw that the near ventricle is actually enlarged, it's dilated. And when I measured it, it's 10.3 millimeters, which is definitely large. So it is very, very important to look at both the lateral ventricles. What do we call as a normal lateral ventricle? A normal lateral ventricle is one in which the frontal horns are directly next to the CSP. The body is filled with an echogenic choroid plexus, and the posterior horn is free of any content. The occipital horn is full of CSF. So the echogenic choroid plexus fills the atrium of the lateral ventricle. This is the atrium where the body meets the occipital horn. And this atrium is filled with choroid plexus, and generally the choroid plexus ends at the level of the parieto-occipital sulcus. This is the cerebral hemisphere on the far side. In the cerebral hemisphere, you have the lateral ventricle. This is the medial surface of the cerebral hemisphere. And that indentation or that notch we're seeing there, at 20 weeks, we generally see it as just a shallow notch. And that shallow notch is the developing parieto-occipital sulcus. That is the landmark that we use to measure the lateral ventricle. Generally, the choroid plexus ends at the level of the parieto-occipital sulcus, or maybe a little after that. So this is how we look at the lateral ventricles. This is how they are seen normally. So how do we measure the lateral ventricles? You take a section, you can use your split screen mode on your machine, take a section of the far lateral ventricle and the near lateral ventricle on two split screens, see that they are symmetric in size. Subjective measurement, eyeballing is enough for the near ventricle, but it is a good practice to always measure it. So once we get our two sections correctly, make sure that we have a symmetric plane. That means the midline, the forks is occupying exactly midline of the section that we have taken. That means the near half and the far half are equal in size, not asymmetric where you're cutting obliquely into the cerebral hemisphere. Even in the section that we take for the near ventricle, we must make sure that it is as symmetric as possible. Once we get these sections, we look at the parieto-occipital sulcus. That's the parieto-occipital sulcus. That is the indicator of where we must measure the lateral ventricle. The medial wall of the lateral ventricle is well seen, occipital horn and the lateral ventricle. Choroid plexus is nicely ending here at the level of the parieto-occipital sulcus. So this is where we have to measure the TVD, or the transverse ventricular diameter at the atrium. The calipers are placed from inner to inner. I've just magnified this section for us to see. The wall is clearly seen and the calipers are placed from the inner surface of the wall to the inner surface of the lateral wall. This gives the TVD, and this axis should be perpendicular to the long axis of the lateral ventricle. This is the long axis of the far ventricle, and I'm placing the calipers perpendicularly. This is the long axis of the near ventricle, and we're placing the calipers perpendicularly. Every one of these steps is extremely, extremely important, because even a minor deviation from this will give us grossly increased values of the TVD, and we may diagnose ventriculomegaly erroneously. If we don't take a symmetric section, we'll take an oblique section, and that naturally increases the size of the ventricle, and we'll get a larger measurement. If we take an oblique measurement instead of a perpendicular measurement, we'll get a larger measurement. So we should make a good practice to follow all of these guidelines. This is just an example to show us how the measurement changes when we take oblique section instead of an axial section. A true axial section, the ventricles are symmetric, and we can see that it is normal in size. But once we take an oblique section, where as it is passing through a larger section of the ventricle, and this will definitely measure more than what we should be getting. Caliper placement, I already said, it is inner to inner, not on to on, not outer to outer, and not somewhere at the end of the occipital horn. It is at the parieto-occipital sulcus. Inner to inner is the best way to measure. What is the normal size of a lateral ventricle? All guidelines now tell us that throughout gestation of second and third trimester, anything beyond 15 weeks, a lateral ventricle should measure less than 10 millimeters. Anything more than 10 millimeters is called abnormal or large. So in the mid trimester, the normal lateral ventricle on average ranges from 4 to 8 millimeters. 9 millimeters is at the +2 standard deviation level, but we still call it upper normal. 10 millimeters is at the +4 standard deviations of normal. So plus 10 and above is definitely termed lateral ventriculomegaly, but we should be watchful whenever the ventricles go beyond 8 millimeters. It is a good practice to follow up these cases at least 3 to 4 week intervals and measure the ventricles to see whether they are progressing into a ventriculomegaly. So the normal size is TVD, transverse ventricular dimension, less than 10 millimeters. The medial wall of the ventricle to the choroid plexus gap is less than 3 mm, and the CP, choroid plexus angle to the medial wall, is normally 16 to 22 degrees. We don't really need to follow the gap between the choroid plexus and the angle. Those are older methods, but I thought I'd just cover it. For example, this is a case where choroid plexus is not exactly filling the entire body of the atrium of the lateral ventricle. There is a gap that you can see here, but this gap is definitely less than 3 millimeters. This is normal. And in the angle, coming to the angle of the choroid plexus, if you draw an angle between the interhemispheric fissure, midline forks, and the choroid plexus, normal is 16 to 22 degrees. And in a severe ventriculomegaly, you get a dangling choroid plexus where the angle definitely increases. But for us, for practical purposes, a 10 millimeter cutoff is what we should stick to, and anything beyond 10 millimeters is called a lateral ventricular megaly. Coming to side variation and variation over time. Like we said, the lateral ventricles are not fixed structures. They're not rigid structures. They're dynamic structures, and they can progress or regress over time. They can either increase in size, which generally does not happen. Normally, the ventricles decrease in size as the fetus grows. Beyond 24 to 26 weeks, as the fetal cerebral hemispheres develop more, the sulci and gyri develop more, the ventricles start normally decreasing in size. So we should know the normal progress, but at any given stage, about 10 is the abnormal cutoff. Side to side, the right to left variation is also normal. Right to left, anything, a difference of less than 2 millimeters is absolutely normal, and it is very, very common. Even if the difference is more than 2 millimeters, but both are less than 10 millimeters, we are still not worried. Only when one of them crosses 8 millimeters, we need to follow it up and see that it doesn't cross 10 millimeters. There are a lot of studies that have been done in isolated lateral ventriculomegaly, and that also, if it is less than 10 millimeters, if it is asymmetry less than 10 millimeters, it is a good prognosis. Coming to the pitfalls in measuring the lateral ventricles, sometimes our image quality is very, very poor. For example, if the maternal anterior abdominal wall is extremely thick and attenuating, we really are not going to get good images. We're only seeing very vague echoes in the intracranium, and we may not be able to differentiate the walls of the lateral ventricle. So by mistake, instead of measuring the walls of the lateral, inside the walls of the lateral ventricle, if we think the entire hemisphere is the lateral ventricle and measure that, we're of course going to be erroneously diagnosing hydrocephalus. And this is a very, very common pitfall that we face. So many times we get referrals saying that lateral ventriculomegaly, 15 millimeters, 20 millimeters, but when we actually take an effort and see in tough cases, it is not that the ventricle is measured, the entire cerebral hemisphere is by mistake measured. So that's one of the pitfalls we need to avoid, and we need to try and optimize the image as best as possible to see the walls of the lateral ventricle well. Another pitfall of measurement of the lateral ventricle, like I said, is an oblique measurement. Instead of taking a perpendicular measurement, if we take an oblique measurement, we're definitely going to get a larger measurement, and that's going to be wrong. Coming to the lateral ventricles in the first and early second trimester, the lateral ventricles are not seen as how we see an S-shaped structure in the mid and third trimesters. In the first trimester, the entire lateral ventricles are filled with choroid plexus, and that is what is prominent, and we see a classical butterfly sign. If we see a midline in fox and a butterfly sign, choroid plexus is forming the wings of the butterfly, this is normal. It is very difficult to see actually the ventricular wall around it unless we do a transvaginal ultrasound. So we'll see one example of lateral ventriculomegaly in the first trimester, but generally this picture in the first trimester is considered normal. Coming to ventriculomegaly, I'm going to be concentrating mainly ventriculomegaly in the second and third trimesters. And the incidence of ventriculomegaly is actually very, very common. It's one of the most common signs we pick up in the second and third trimester. Incidence is as high as 1.5%. That means in every 100 babies that we scan, we should be expecting to pick up one at least with a ventriculomegaly. So this is what I was talking about in the early 11 to 14 weeks. If the choroid plexuses don't fill the entire ventricles, we're not seeing a classic butterfly sign, we're seeing a roomy space, then we should consider this as a lateral ventriculomegaly, even if it does not measure more than 10 millimeters. And another additional sign in this case is choroid plexuses in the choroid plexus as early as 14 weeks. This is a transvaginal scan, so that's why we see the nice differentiation between the ventricular walls, the choroid plexus, and also the cerebral mantle as early as 11 to 14 weeks. So ventriculomegaly, we know, is any ventricle that measures more than 10 millimeters in the second and third trimesters. But this term refers to the dilatation of the lateral ventricles without implying a specific cause. Therefore, this is only a sign, it's only a finding and never the final diagnosis. So we must never ever report in our impression as diagnosis lateral ventriculomegaly. That is not a diagnosis, it is a finding, it is a sign. It's as if we say diagnosis ventriculomegaly, it's as good as a physician saying diagnosis fever. Fever is the sign. We need to find out why the fever is occurring. So the same way ventriculomegaly is a sign. Once we pick up a sign of ventriculomegaly, we need to classify it. Is it mild or is it moderate to severe? Mild ventriculomegaly is anything that measures 10 to 15 millimeters. Mild and moderate. Severe ventriculomegaly is more than 15 millimeters. So mild marginal ventriculomegaly it's also called borderline when it is closer to 10 millimeters. And in this, the medial wall to choroid plexus gap is 3 to 8 millimeters. That's another additional sign. And in severe ventriculomegaly, it's also called frank or overt ventriculomegaly. And the gap between the medial wall and the choroid plexus increases beyond 8 millimeters. That's again an additional sign. Coming to mild lateral ventriculomegaly first, MVM or mild ventriculomegaly. What are the causes? There are multiple causes, and few of those are neuronal migration disorders, structural abnormalities in the brain, example, agenesis of corpus callosum, etc., chromosomal abnormalities, aneuploidy, fetal infections, hypoxic ischemic insults, intracranial hemorrhage, intracranial cysts and tumors, inborn errors of metabolism, and other single gene disorders, syndromes. Once we have ruled out all of these other causes as much as we can on ultrasound, on MRI, on other tests that we do, maternal serology, genetic testing, invasive testing, after we've ruled out all of these, then we can call the ventriculomegaly as isolated. So that is an important term that we need to remember. Isolated lateral ventriculomegaly is the term used when all of these causes have been ruled out. But the greatest challenge for us as diagnosticians is actually to call a ventriculomegaly as isolated. Why is it important to make out whether the ventriculomegaly is isolated or non-isolated? Because that is what directs our counseling. That is what directs prognosis. Prognosis in non-isolated ventriculomegaly is completely different. It's dependent on the cause, and isolated ventriculomegaly is completely different. So for us, the challenge is to correctly identify whether a fetus, a case with ventriculomegaly is isolated or non-isolated. And how do we go about doing this? We go about doing this by additional tests, additional steps that we need to take. The first step is to do an extended neurosonogram, that is either by transabdominal or transvaginal approach. And if not possible, then we can even use fetal MRI as a help. So an extended neurosonogram is extremely important to find additional intracranial findings. And apart from that, the next step is to do a detailed anomaly scan. Especially in the mid-trimester, we have to run through the entire fetus in detail, see that we are not missing any other markers of aneuploidy, markers or sequelae of infection, any other patterns of anomalies that will help us fit a diagnosis of ventriculomegaly into a syndrome. So let's see how we need to go through these steps. In an extended neurosonogram, after the first lead finding of ventriculomegaly, we go on to an extended neurosonogram, and we need to go through a whole list of structures that we have to check. These include the corpus callosum form and thickness, cortical sulcation, cortical thickness, ventricular wall irregularity, periventricular nodules, periventricular echogenicity, periventricular cystic foci, calcification, and of course the posterior cranial fossa. So this is the entire list that we have to run through, check all of these structures to see if we are finding any other abnormalities in all of these. So how do we do a neurosonogram? Can we do it transabdominally? Yes, we can do an extended neurosonogram transabdominally, but it depends on the fetal position. Sometimes the fetus is positioned in such a way that not all sections are possible directly by a transabdominal scan. We may have to use a 3D approach. We may have to try and wait for the fetus to move. But if the fetal head is at the lower pole of the uterus, is at the os, then the best way to do a neurosonogram is by a transvaginal approach. A transvaginal neurosonogram is extremely useful because it gives extremely high resolution images. We can get direct coronals and direct mid-sagittals, parasagittals, depending on the fetal head position. And this is so good in resolution that it may even obviate the need for MRI. The resolution in ultrasound, spatial resolution is actually better than MRI. The tissue characterization is better on MRI, but ultrasound scores over in spatial resolution. So whenever possible, we must do a transvaginal approach. This is just an example to show us a case of 26-week fetus where the ventricles were dilated. On transabdominal scan, this was the mid-sagittal section. I could not see the corpus callosum very well. I just couldn't comment that this is a normal corpus callosum. So I did use a transvaginal approach to get better mid-sagittal sections. And this is the kind of clarity that we see on a transvaginal approach. Just look at the corpus callosum. It definitely is not smooth and even in contour. It has a narrowing here, it has another narrowing here, it's lumpy at the end, it's lumpy at the genu. So this is definitely a dysgenetic corpus callosum. And a transvaginal neurosonogram is what helped me make this diagnosis. And the parasagittal sections also on transvaginal scans are brilliant in resolution, because you even get the laminar pattern that we normally expect in the cortex. So always, always please do a transvaginal approach of neurosonogram if it is possible. The next step we need to take is do a detailed anomaly scan and go through all the associated anomalies that one could possibly expect in a case of ventriculomegaly. In the CNS, by an extended neurosonogram, we have to rule out neural tube defects, agenesis of corpus callosum, Dandy-Walker malformations, cortical atrophy, sulcation abnormalities like agyria, lissencephaly, heterotopia, that is malformations of cortical development, and posterior cranial fossa cysts and abnormalities. Extra CNS anomalies commonly associated with ventriculomegaly are omphalocele, amniotic band syndromes, esophageal atresias, duplex kidneys, congenital diaphragmatic hernias, congenital heart defects like VSDs, ascites, hydrops. All of these other additional findings will help us pattern recognize and try and get the final diagnosis of what the cause of ventriculomegaly is. So what is the protocol for mild lateral ventriculomegaly? First, measure both lateral ventricles. And if either one of them crosses 10 millimeters, we have to do an extended neurosonogram, either TAS, TVS is best, or 3D neurosonogram. Extracranial associated anomalies have to be looked for in detail by a detailed anomaly scan. Next, all lateral ventriculomegalies crossing 10 millimeters, mild lateral ventriculomegalies, should be offered a karyotype. And I'll go one step further and say right now we are moving into the era of microarrays. Rather than a karyotype, a chromosomal microarray is what is preferred for a ventriculomegaly now. I'll even show you an example of that because it has an additional yield for microdeletions and duplications. So ruling out aneuploidies is a must. Torch screening is the next step that we take. Torch screening in the mother, both IgMs and IgGs must be done. And if we're doing an invasive testing for karyotyping, then we can directly even test the fetus by a PCR. But that should be done only after 6 to 7 weeks. We'll look at that as well. If these steps are all negative, if the neurosonogram is normal, there are no associated anomalies, karyotype or CMA is normal, torch screening is normal, no infection. If all of this is negative and then we move to 26 weeks, we can offer a fetal MRI to rule out heterotopia and certain types of agyria with subcortical band heterotopia, which cannot be made out by ultrasound. So that is an advantage of MRI. And if that is also normal, then we do a serial ultrasound follow-up every 4 weeks in this fetus to see the progress of these ventricles. Are they remaining stable? Are they decreasing, or are they increasing in size? That is how we prognosticate depending on the size variation. And after the child is born, we also must do a neonatal neurodevelopmental follow-up. Why is serial examination important? Like I said, we need to see whether the ventricles are stable or regress or progress. In a lot of studies that have been done, 34% of lateral ventriculomegaly cases decreased, 56 were actually stable, and 16% actually progressed. So we have to keep a watch on these. Every 2 to 3 week intervals, 3 to 4 week intervals, we study the lateral ventricular size. And what is the prognosis? If the ventricles regress, the risk of developmental delay is still 4.2%. If they're stable, it is still 4%. But if the ventricle sizes progressively increase, then it is bad. 16.7% of them will have developmental delay. So this is the importance to always monitor the fetuses. It's not enough to just pick up a lateral ventriculomegaly and then leave it alone. No. Do all the next protocol steps. Even if everything comes negative, leave them alone? No. Still follow up every 3 to 4 weeks to see what is happening to these ventricles. So we've seen that a lot of associated anomalies are common, and we'll come through, we'll look at them through cases. So I've drawn a very simplified chart over here. And whenever we see a mild lateral ventriculomegaly, this is a picture we need to get in our mind immediately. Mild lateral ventriculomegalies, 5 possibilities, and these are the steps we need to take care of. The 5 possibilities are aneuploidy or single gene disorders, infection, other neural malformations either in the brain or the spine. It can actually progress, so we have to keep a watch on it. And if everything is normal, then we consider it as a normal variation. So all of these steps we need to, the causes we need to keep in mind. So a truly isolated ventriculomegaly is when we've ruled out everything else, when there are no additional intracranial findings on neurosonography, there are no additional associated anomalies we find on an anomaly scan, all imaging findings are normal, the karyotype or the CMA is normal, there is no CMV or toxoplasma IgGs or IgMs, the fetus it does not have fetal infection, fetal MRI is normal, then we call it a truly isolated ventriculomegaly. And then we can call it as maybe a normal variant. Measurements that are closer to 10 millimeters are more likely to represent a normal variant, particularly when they are isolated. A lot of studies have been done on this as well, and fetuses with TVD of 10 to 12 millimeters are found to have normal postnatal outcomes in up to 90% of cases. So once we know that it is isolated, we can kind of reassure the couple and say 90% of these fetuses actually do well. So mild lateral ventriculomegaly may represent a normal variation once we have ruled out all other associated findings, and 90% of them do well, but still about 10 to 11% may have neurodevelopmental delay. So this is the prognosis we need to give the couple. This is an example now, the first case example that I'll take you through. This is a lady that came to us at 23 weeks of gestation. The standard axial transventricular plane sections over here, we can definitely see that the lateral ventricle is looking more prominent than usual. The frontal horns itself are prominent. The occipital horns are prominent. And once I measure them, I'm getting a measurement of 9.6 on the far side and 10.2 on the near side. Definitely that's borderline ventriculomegaly. I did an extended neurosonogram. The corpus callosum was normal on mid-sagittal section. The sulcation was normal for 23 weeks. There was no periventricular cysts or nodules. The ventricular margins are normal. Contour is smooth. There are no other findings of calcification or echogenic foci or bleed. We did advise invasive. So this was a case of about 3 or 4 years back, when the chromosomal microarray was not as yet very, very popular. So we did advise a karyotype, and this is the procedure that we did. An amniocentesis, amniotic fluid was sent for karyotyping, and the karyotype in this fetus was normal. So the karyotype was normal. Her maternal TOT screening was clear, no infection, no other findings on neurosonography. So at 23 weeks, we told her that she can wait, and she came back to us at 27 weeks for the next follow-up, and the ventricles had progressed. They had increased to 12.8 and 12.7. We did another extended neurosonography. We looked at the parasagittal sections. The ventricular margin is absolutely smooth, no cysts, no nodules, no indentation of the margins, no echogenic bleeds or no calcifications. The sulci are normal for 27 weeks. Look at the sylvian fissure. It's already acute angles. The operculation has already started. The parieto-occipital sulcus is quite a deep V. So the sulci are also normal for 27 weeks. That is another good sign. At 27 weeks, there were no other findings, but the ventricles had progressed. So we did advise a fetal MRI for her. The fetal MRI also showed no additional findings. The sulcation was good. There were no other heterotopia or findings on MRI. So this fetus, this pregnancy, they did continue, and follow-up, neonatal follow-up at 3 years of age, this child is doing well. So this is a classic example of isolated mild lateral ventriculomegaly with no other findings, all investigations coming clear, and the child is actually doing well. So let's come to a few examples of structural abnormalities that we have found with lateral ventriculomegaly. So the first step we need to do is an extended neurosonogram. And on the extended neurosonogram, we already are prepared to find structural abnormalities like Dandy-Walker malformation, complete agenesis of corpus callosum, malformations of cortical development, neural tube defects, and schizencephaly. Let's see a few examples. This is the first example that I'll show you. This is an axial transventricular view at 28 weeks. The first sign, glaringly obvious sign that we must notice, especially after Dr. Indrani's lecture just before, is that the CSP is absent. The interhemispheric fissure is uninterrupted. There is no nice rectangle box over here. The CSP is absolutely not seen. The frontal horns are far apart from the midline, and the shape of the lateral ventricles is teardrop shaped. Teardrop shaped lateral ventricles with colpocephaly. The colpocephaly is what gives the ventricular dimension more than 10 millimeters. So this is a classic example of all the indirect signs for complete agenesis of corpus callosum. And there we have it. We turn the probe to the mid-sagittal section. And on the mid-sagittal section, we expect a nice corpus callosum here, but that's absolutely not seen. There are radiating sulci. The CC is completely absent. And this is an example of lateral ventricular megaly, colpocephaly. In a case of complete agenesis of corpus callosum, even the pericallosal artery shows us the radiating abnormal pattern. So that's the first sort of example that we see in lateral ventricular megaly. This is another example at 29 weeks. This case was referred to us for lateral ventricular megaly. The ventricles are definitely prominent. Frontal horns are prominent, measuring more than 10 millimeters. I turn the probe coronal, and on coronal, you see that the frontal horns are prominent. The CSP is small. The CSP is small even on the axial section. It is small on the coronal section. That again gives us an alert that there must be something abnormal in the corpus callosum. So we do a mid-sagittal section for this case as well. And in this case, what we find is that the entire corpus callosum is present, but it is extremely thin. For a 29 weeks fetus, this is not the kind of look of corpus callosum that we expect. It's a nice chunky normal corpus callosum is at least 3 to 4 millimeters thick in a 29 weeks fetus. But in this, the entire length is present, but the thickness is very, very less. I think one of the delegates actually asked a question in the chat. I think Dr. Sachin was asking how to differentiate a partial agenesis of a corpus callosum versus a thin or a hypoplastic corpus callosum. This is a classic example of a hypoplastic corpus callosum where the entire length is present, but it is the thickness that is very, very less or thin. In a partial agenesis, the entire length is not present. It is only part of the corpus callosum that is present. So this is another example of how the lateral ventricles is the first lead sign that was referred to us, and then we made a diagnosis of a callosal dysgenesis. This is another example of a 35 weeks fetus that was sent to us for second opinion for a rhabdomyoma, cardiac rhabdomyoma, and the same fetus also had unilateral left lateral ventriculomegaly. But again, it was a 35 weeks fetus. The imaging was not very great by ultrasound because the head was at the fundus. We couldn't do a transvaginal neurosonography. And 35 weeks, it is anyway difficult because the fontanelles are starting to close. So we did refer this lady for an MRI. And on the MRI, we found a nice dark hypointense mass at the level of the foramen of Monro on the left side. So this mass lesion over here is actually what is causing obstruction to the foramen of Monro and causing a unilateral left lateral ventriculomegaly. So this is a classic location of a subependymal giant cell astrocytoma. A rhabdomyoma, already our antennae alert, we need to think of tuberous sclerosis. Tuberous sclerosis, we do expect intracranial tubers, we expect a giant cell astrocytoma, and in this case it was a giant cell astrocytoma causing lateral ventriculomegaly, and we can also see other tubers in this fetus on fetal MRI. So that is an example of malformation of cortical development leading to ventriculomegaly. Another case example here at 20 weeks, we see that the ventricles are prominent, but at 20 weeks, no other finding was seen. The ventricular margins were normal. The parieto-occipital sulcus was okay, normal for 20 weeks. The anterior complex was normal, corpus callosum was normal. And the other investigations, karyotype was normal and no infection was found. This couple waited till 26 weeks to study the sulcation. We know we need to wait till 26 weeks to study the sulcation. At 26 weeks, the ventricular size had progressed. It had become quite more than what we expected. And 26 weeks, the sylvian fissure is still very, very open. It's not becoming acute angles like how we expect it. It is still a smooth contour. The posterior cranial fossa cerebellum is small. So all of these are additional findings telling us that this fetus is going in for agyria and a malformation of cortical developmental encephaly. That's another third cause of lateral ventriculomegaly. Another example over here, this was a 20 weeks fetus. At 20 weeks, the ventricle was normal, but what we noticed in the posterior cranial fossa was the cerebellar hemisphere was indented upon by an extra-axial cystic mass lesion. So this was diagnosed as an arachnoid cyst. We did send her for a fetal MRI. The fetal MRI agreed. There was a posterior cranial fossa cyst, not in the midline, off midline, and it is causing mass effect, pressure effect on one of the cerebellar hemispheres, and that was called a posterior cranial fossa arachnoid cyst. So arachnoid cysts are generally good prognosis. They're not very, troublesome in nature. So we asked this lady to wait, and she came back to us at 25 weeks for a follow-up scan. But on 25-week scan, both the lateral ventricles had increased in size. They had progressed to ventriculomegaly. The arachnoid cyst had increased in size. And what was actually happening was that the arachnoid cyst was compressing the fourth ventricle and causing obstruction to the flow of the CSF. So this was a progressive ventriculomegaly in a case of posterior cranial fossa cyst. Another example over here, 22 weeks fetus. On 22 weeks, the ventricles definitely were larger in size. And what is more glaringly obvious is this echogenic part over here in the anterior complex. We don't expect the choroid plexus to continue into the frontal horn. There is an abnormal echogenic area over here, and that is a classic location of a germinal bleed. And once we put on a Doppler for the MCA Doppler and do an MCA Doppler, the velocity was definitely more, telling us that there is anemia in this fetus because of the bleed. So this was a germinal matrix bleed causing a ventriculomegaly. A fetal MRI was done in this case, and definitely there was a germinal matrix bleed, which was the cause of mild lateral ventriculomegaly. This fetus, of course, will have to be followed up, and the mother and the fetus will have to be investigated for bleeding disorders, clotting and bleeding disorders. Another abnormal neural cause of ventriculomegaly is definitely neural tube defects, open neural tube defects. We're all very, very used to this. As soon as we see the head, we see a lemon-shaped skull, we see lateral ventriculomegaly, we go to the posterior cranial fossa, there is a banana sign. We know that this is a Chiari-2 malformation. We already expect that there is an open neural tube defect. Once we study the spine, definitely there's an open neural tube defect in these three different cases that I've shown you. It can either be bulging, it can be just a flattish myeloma, or it can even just be an open defect without a bulge, without a myelomeningocele. And these are the most tricky because these are the ones that are missed. If at all we don't image the spine with a layer of fluid over it. So in this case, it was almost half the spine that was open, causing a open neural tube defect and ex vacuo phenomenon of lateral ventriculomegaly. Am I audible?
Yes.
Am I breaking up? Okay.
Yes, you're audible, but we're running short of time.
Oh, I'll quickly finish. So another 5 minutes may I take? I'm approaching the end of ventriculomegaly. I mean, mild ventriculomegaly. So the next important cause of lateral ventriculomegaly is aneuploidy. Aneuploidy is very common in lateral ventriculomegaly. Every single case has to be worked up. This is an example of an 18-week fetus, bilateral ventriculomegaly, no other findings, but the karyotype, the triple test was positive, and the fish turned out to be as trisomy 21. Another example, EICF, echogenic intracardiac focus, mild lateral ventriculomegaly, polydactyly. This turned out to be a trisomy 18. Another example of SUA, lateral ventriculomegaly, which turned out to be a case of trisomy 21. So every single case must be followed up for a karyotype. The next important, I'll skip this and I'll go to infection. The next important cause of ventriculomegaly is fetal infection. Again, 5% of ventriculomegaly is caused by CMV or Toxoplasma or Zika virus. And it is extremely important to do a maternal torch and also a fetal direct testing if we're doing an invasive testing. But that will be positive only after 6 to 7 weeks of fetal infection. The signs of infection in the intracranium are ventricular septae, calcification around the ventricles, cysts around the ventricles, and all of these can cause atrophy of the mantle and therefore ventriculomegaly, porencephaly, aqueductal stenosis and therefore ventriculomegaly, and also a communicating hydrocephalus. This is a classic example of CMV where there is dense nodular calcification all around the ventricles, and the ventricles are enlarged. The cerebral mantle is very, very thin, and this turned out to be a case of CMV infection. This is another interesting case. At 25 weeks, this lady came to us with a history of dengue fever in the 3rd month of pregnancy. The only finding was lateral ventriculomegaly 10 millimeters. And after that, we did suggest all of the following steps, but she was lost to follow-up. She didn't really come back to us for any of the tests. After birth, the neonate came back to us at 28 days for a neurosonogram, and the neurosonogram showed us a full-blown aqueductal stenosis. So that's another case to show us that it is very, very important to follow up these cases. So we've seen all the different causes of lateral ventriculomegaly that can differentiate between isolated and non-isolated. The prognosis depends on that. Isolated ventriculomegaly, the prognosis is good, 90% survival, good neurodevelopmental outcomes in about 80 to 90%. Non-isolated survival is poor and the neurodevelopmental outcome is poor. So we must make sure that we go through the entire protocol and do a good detailed study to differentiate the two. Just a couple of minutes on severe ventriculomegaly, because this is an easier thing. Severe ventriculomegaly is either due to obstruction, cerebral maldevelopment, or atrophy. If the diagnosis is far more straightforward, the prognosis is generally poor in all severe ventriculomegaly, irrespective of the cause. This is an example where both the ventricles were much more than 15, 18 millimeters. And this was turned out to be an aqueductal stenosis. Classical triad, lateral ventricles larger than 15 millimeters, 3rd ventricle dilated, normal 4th ventricle. We must think of aqueductal stenosis. Another example of malformation of cortical development, severe lateral ventriculomegaly. The orbits were asymmetric in size. There was an intraorbital mass focus, retinal detachment over here. And this is, again, a classic finding in Walker-Warburg syndrome. And that's a malformation of cortical development or cobblestone malformation. That's the child after it was born with retinal detachment. Meckel-Gruber syndrome, encephalocele, gross lateral ventriculomegaly, hyperechoic kidneys, and polydactyly, which must suspect ventriculomegaly. Intracranial hemorrhage is another cause for severe lateral ventriculomegaly. So that was the differences between mild and gross lateral ventriculomegaly, and the protocol we must follow. The protocol is extremely important. Ventriculomegaly is not a finding, but not a diagnosis, but a finding, and we must follow the protocol to either call it isolated or non-isolated. Isolated ventriculomegaly must be branded only after this entire protocol is followed. In isolated, the prognosis is generally good, but the counseling is difficult because still 10% may not do well. Non-isolated, the prognosis is dependent on the cause, and that gives us a better handle to prognosticate these couples. Severe ventriculomegaly is easier to diagnose and easier to prognosticate because they're not very good. So that's the protocol. Again, this is important. Please go through all of these steps and then come to a diagnosis. Thank you very, very much for a very patient hearing.
Thank you, Rachita. That was absolutely marvelous. As fantastic and even better than expected. Thank you for those protocols. We will, before we move on to our last talk, a few announcements. One is that we have some slots still available in the Genoa Symposium from the 26th to the 28th of November. This is going to be a virtual symposium which has been executed by Dr. Dario Palatini, and we have a 50% discount available for SFM members. And please be in touch with Vishal Mittal in the office, and he will guide you through the whole process. Also that we tomorrow morning have a fantastic parade, if I may call it, of new talent with Society of Fetal Medicine. And our president, Dr. TLM Praveen, has organized a webinar starting at 9:30 a.m. And I know there's going to be a lot of hectic activity this weekend, but don't miss it, because for those of you who want to learn how to present, it's an excellent exercise. For those of you who want to learn, an exercise in learning, and for those who want to learn how to lead, it's an excellent exercise in leading, a great chance to learn. There is also news for Dr. Hasmukh Lal has reminded me to let you know that during the 3 days with Rabi Chawi, we had an excellent panel discussion on the prognostication of anomalies of the central nervous system of the fetus. And that is now on YouTube. And for those of you who wish to access it, it is accessible via the Society of Fetal Medicine website. And it has some excellent discussions there, both from a imaging and a genetic point of view. We will answer the questions at the end of the session. And I take this chance to invite Dr. TLM Praveen to now give his presentation on the posterior cranial fossa. I look forward to his presentation.
Thank you, Ashok. Shall I share my screen?
Yes, please.
Yeah, okay. Fine, okay. Good, can you see my screen?
Perfect, we can hear you and the pointer is working.
Yes, fantastic, thank you. Good evening, everybody. And it's indeed a very, very, very long evening, but various aspects of the central nervous system has been covered by various eminent speakers, and almost most of the aspects of the anterior complex as well as the various aspects of ventriculomegaly and other things have been covered. So I will be left off with what is called as the posterior fossa evaluation. One thing I know, you are all tired because it's already almost nearing 10. But as far as possible, I'll take you through as much as giving you a lot of information as far as the possibility. Now, first and foremost thing is, as far as the posterior fossa lesions are concerned, they are rare. But the variation is that they vary from normal variants to a severe central nervous system abnormalities. So that is the reason why we need to have an absolutely optimal imaging techniques in evaluating the posterior fossa. We have been going through the various aspects of evaluation of the central nervous system, right from the conventional axial as well as the coronal and sagittal sections. There are certain important aspects that we need to understand while evaluating the posterior fossa. The reason is that the posterior fossa is one of the structures which are very difficult to access or at the same time evaluate unless you have a correct plane to image the posterior fossa structures. Now, once you have applied this optimal imaging techniques, then you need to understand the midbrain and hindbrain structures, first and foremost thing, and then their morphology, at the same time, the biometry, that is the size of these structures. So whenever you try to evaluate the posterior fossa structures, the most important thing that there are three aspects that we need to understand. One is to evaluate them properly, that is get an image, proper image. Second one is to evaluate the morphology of the structure. Third one is to evaluate the size of the structure. Fourth one is to evaluate the location of the structure. So basically, these are the three most important things. That is the morphology, size, as well as the location of these structures, which are either they are normal or abnormal. So once you understand the morphology and the biometry, then you know that you can easily deal with identifying the abnormalities of the posterior fossa. So we will start off with evaluating the embryology. Basically, this has been already told to you in the neuroembryology, where we know that the primary vesicles are the porencephaly, mesencephaly, and the rhombencephalon, whereas the porencephalon is the one which again divides into telencephalon and diencephalon, which all the other structures that are going to develop from it, and rhombencephalon and the mesencephalon are the ones which we are interested in. That is what constitutes the hind and the midbrain of the fetal brain. So keeping this in mind, we need to understand that the brain posterior cranial fossa is the structures that are present between the foramen magnum as well as the tentorium. The various anatomical structures which are going to go through them are the cerebellum, cerebellar vermis, fourth ventricle, midbrain, pons, as well as the medulla oblongata. These are the most important structures that we are going to identify as far as the posterior fossa is concerned. Now, coming to the development of the hindbrain, it is being regulated by what is called as the isthmus organizer. This isthmus organizer function as well as the formation is basically dependent on various genes. So this is one of the most important concepts that we need to understand. Now, we all know that the vermis develops from the anterior membranous area, whereas the Blake's pouch is the one which develops from the posterior membranous area. Blake's pouch is a normal structure. And then this AMA, that is the anterior membranous area as well as the posterior membranous area, are separated from one another by what is called as the plica choroidae. And this plica choroidae is the one which develops into fourth ventricle. This is what we need to understand as far as the posterior fossa embryology is concerned. Now, We also have to understand that there is a lot of evolution that takes place, as it has been repeatedly pointed out to you, that brain is an evolving structure. So basically, when we start off evaluating the posterior fossa at 13 weeks of gestation, what we find is the brainstem will be kinked, the midbrain will be large, as well as the pons will be small, medulla oblongata will be elongated, vermis will be small, whereas the fourth ventricle will be very, very large. As it develops into 16 weeks and above, then what happens is there will be straightening of the brainstem. As you can see here, there will be straightening of the brainstem. The midbrain becomes small, the pons becomes larger, and then the vermis becomes larger, as well as the fourth ventricle becomes smaller. So this is how the evolution takes place. So that is the specimen, and these are the sonoanatomy that you can understand while when you start off evaluating these fetuses right from 10 weeks onwards. This is the sagittal section where you can see the posterior fossa components. At 12 weeks, you can see a nice kinked brainstem, as well as the choroid plexus, that is the plica choroidae, as well as in the 14 weeks, you still have some amount of kinking, but then you start developing or seeing the fourth ventricle, as well as the small vermis, which can develop further as it by about 16 weeks of gestation. You see a little bit bigger vermis, and by 20th week, you can see this one. Now, when you take the structures, it is the configuration is the brainstem is that is the midbrain is 1, the pons is 2, and the medulla oblongata is 1. That is the size configuration as far as the various hindbrain structures are concerned. Now, the approach, how do you evaluate this? The most important thing which we have to understand is there was a very drastic statement made by Dario Palladini in his talk, stating that from hereafter, whenever there is a paper that has been sent for publication or for a peer review, he says that if the paper consists of evaluating the posterior fossa transabdominally, it is as better as reject that paper. So that is the impact that the transvaginal has caused, and that is the information that we are going to get by doing a transvaginal examination. So posterior fossa, transvaginal is the method of evaluating, and the posterior frontalla is the route through which you can evaluate various intracranial structures. Now, the basic two sections that we need to take is, one is the coronal section, where you have the transcerebellar section, where you can see 2 cerebellar hemispheres and the echogenic vermis, as well as the sagittal section through the posterior fossa. When you can see these posterior fossa structures, you can see beautifully the thalamus, the midbrain, the pons, as well as the medulla oblongata. You can see the vermis. You can even see the aqueduct, that is the tectum, that is the fourth ventricle, and the fastigium, and that is the cisterna magna. So these are all the structures that can beautifully be demonstrated by just doing a transvaginal posterior frontal approach, which gives us. So that's the reason why I said it is slightly deviating from the routine evaluation of fetal brain. The posterior fossa, particularly, you need to get a good access to the posterior frontalla in order to understand these structures. Now, not only that, as we all know that we need to understand the mesencephalon. That is one of the most important things that we need to evaluate as far as the posterior fossa structures are concerned. This is the third ventricle that you can see. This is actually through the anterior frontalla. When you inseminate the fetal brain, you can beautifully demonstrate the corpus callosum, that is the cavum septum pellucidum. That is the third ventricle, which can be very nicely dilated to come onto the aqueduct. So this is how you can evaluate the mesencephalon, that is the mesencephalon. Now, coming to the medulla oblongata, you have what is called as the innominate suture. Through the innominate suture, when you inseminate, you can beautifully see the midbrain structures, as that is the pons, that is the medulla oblongata, which continues into the spinal cord. So these are the sections that you need to take in order to understand the posterior fossa anatomy. Now, it is said easy that always you need to do a transvaginal, but then if the fetus is in the breech position, it becomes very difficult. You still try to do an external version, but then it's not that easy as it is said. So at times you may be left off by doing what is called as the 3D volume acquisition. So in the 3D volume acquisition, of course, this was actually done with the transvaginal examination, where I could see the corpus callosum. And remember, whenever you call it as a mid-sagittal section, the most important thing that we should remember, whether it is true mid-sagittal or not. The reason is, if it is not a true mid-sagittal section, the structure which you are seeing in the posterior fossa, which is supposed to be vermis, may not be vermis. It will be actually the cerebellum that you are going to see, because you are away from the mid-sagittal. But then how do you know that it is exactly the mid-sagittal? One, by doing a 3D acquisition and exactly cutting the brain at the midpoint. The second important thing is that the corpus callosum and the vermis police each other. So whenever you get a good mid-sagittal, true mid-sagittal section, you should see both the corpus callosum as well as the vermis in that particular section. Then only you know that you are dealing with an exactly the mid-sagittal section. Now, the axial section is also an extremely important section that will also help us in evaluating in the posterior fossa, particularly when you have what is called as the occipitobregmatic view, where you can see the echogenic, the rectangular echogenic area, and just in front of it, we will see the fourth ventricle. Not only that, you can also see what is called as the interpedicular fossa, which is very, very important as far as the Joubert syndrome is concerned. Just a section just below that, you can find the pons. And you can see these are the superior cerebellar peduncles, which are very clearly seen. And these are the structures that have to be evaluated as far as the axial view is concerned. Now, coming to the evaluation of vermis and cerebellum, because as I said, it is important to evaluate the morphology of these structures also as well as the biometry. So morphology of the structures is that when you do a posterior fossa, you can beautifully demonstrate, and you know that you are dealing with a correct mid-section because you can see the corpus callosum, you can see the tila choroidae as well as the tectum, and wonderful the vermis with the fastigium and the posterior, the cisterna magna. This is the coronal section where you can see the fourth ventricle, and you can even see the choroid plexus, which are seen just below the fourth ventricle. So that's how you have to evaluate the coronal section of the the posterior fossa. Now, coming to the axial section, as I said, this is the occipitobregmatic view, where you can see a beautiful echogenic vermis, and you can see a nice rectangular fourth ventricle. The important aspect of this particular section is that you need to evaluate the fourth ventricle where it is lateral to lateral more than the AP diameter. This is an extremely important point that you can grasp in this particular section. So a normal fourth ventricle should be larger from lateral to lateral and less than on the AP diameter. So that is an extremely important picture, because whenever this parameter is altered, it indicates that there is some abnormality in the posterior fossa, which I will take you through. Now, once that is done, we will go through the morphology. As we know, this cerebellar vermis has got 3 lobes, which we can appreciate. Actually, there are many more lobes, but we will not be able to appreciate by the ultrasound examination. The 3 lobes are first divided into an anterior lobe or by the primary fissure, and then the posterior lobe, and the ratio is between 1 to 3. That is, anterior lobe or the upper lobe is actually 1, and the other one is about 2. So this is how the demarcation is. That is the primary fissure, which divides into the upper lobe as well as the lower lobe, or the superior and the inferior lobes of the vermis. So this is as far as the vermian morphology is concerned. The size of the vermis is concerned, we need to take the caudocranial section of the measurement as well as the AP diameter of the vermis. Not only that, the present situation is that we need to concentrate more on the area of the vermis, which is going to be extremely important as far as evaluation of various abnormalities, particularly concerning with the vermian hyperplasia. Now, this is a typical case where you can see that the vermis is absolutely small when compared to this one. As you can see that is the vermian area, which tells us the importance of evaluating the vermian area very accurately. Now, when we take the vermian biometry, basically when we take the measurements of the vermis, particularly the craniocaudal as well as the AP diameter, and then we need to take the ratio, because all the sizes of the vermis is linearly in relation to the gestation age. So that is the reason why we need to take the biparietal diameter as a baseline parameter, which can help us to calculate the ratio between the various measurements of the vermis. The most important measurement is the vermian area by the biparietal diameter. If the ratio is less than, cutoff is about 1.1, which has a sensitivity of about 84% and the specificity about 99.8%. If the vermian area by biparietal diameter is less than 1.1, you know that you are dealing with a Blake spot cyst. But if the vermian area by biparietal diameter is less than 1.1, you know that you are dealing with a vermian hypoplasia. Obviously, it indicates that the size of the vermis is smaller. That is the reason why the ratio is less than 1.1. So these are the parameters that you can even put it on a graph, which can tells you that exactly where the sizes are matching with. Now, That is as far as the morphology is concerned, and then the biometry is concerned, and now regarding the location of the vermis is concerned. And whenever there is a vermian hypoplasia, we need to assess the location of the vermis, because the location of the vermis is one of the most important factor in identifying various posterior fossa abnormalities. The normal brainstem vermis angle. See, this is the brainstem vermis angle where you draw a line along the dorsal aspect of the brain, midbrain, and another line along the ventral aspect of the vermis, which gives us the brainstem vermian angle. And the normal fetus is usually less than 20 degrees. In a Blake's cyst, it is about 25 to 30. Vermian hypoplasia is 30 to 40. And the Dandy-Walker malformation is more than 45. But remember, this particular one has been put to test. As it has been put to test, the reason is that unless you take an appropriate posterior fossa section where you can see a well-defined midbrain as well as the vermis, by taking a section like this where you don't even see the midbrain, there is no way that you can calculate the brainstem vermis angle. So that is the importance of getting an appropriate section of the posterior fossa where you can draw a line along the dorsal aspect and the ventral aspect of the vermis, which gives us the brainstem vermis angle. Now, as I said, this has been put to test, wherein the number of cases which were done in 2004 were very, very minimal. So that is the reason why there was a nice demarcation between the various pathologies, where they have demonstrated that the normal brainstem vermis angle is about 20 to less than 20. Blake's cyst is about less than 40. Vermian hypoplasia, it is more than 40, and the Dandy-Walker malformation is more than 60 or 60. But then, as the number of cases have increased, the recent 2019 Palladini paper in UOG, that is the White Journal, states very clearly that there is a lot of overlap between the Vermian hypoplasia and the Blake's cyst. So this particular parameter in evaluating the location of has been questioned very much as whether it is really going to be useful to us in our day-to-day practice. This is obviously the statistics which tells us that when you take the brainstem vermian area, that is the, you can see that in the Dandy-Walker malformation, brainstem vermian angle, it is about 62. That is when the gestational age is about any gestational age, that is any gestational age right from the mid-trimester scan. When the vermian hypoplasia, the brainstem vermian angle is this much. Blake's cyst is 21. So almost they are overlapping each other. That is the reason why it becomes very difficult for us to really make use of this particular parameter in assessing the location of the vermis. Whereas the other one is by taking the vermian area as well as the biparietal diameter, we can see very clearly that in vermian hypoplasia, the cutoff is 1.0. As we know, it is 1.1. In Blake's cyst, it is 1.3. So 1.3 is more than 1.1. That the ratio is, and so it is very suggestive of a Blake's cyst, whereas in vermian hypoplasia, it is 1. So similarly in the gestational ages, less than 23 also has been evaluated. Now, the next step that is going to be useful to us in evaluating the posterior fossa lesions is identifying the location of the fourth ventricle, that is the fourth ventricle choroid plexus. The most important thing which we realize is the location of fourth ventricle choroid plexus is identified only when there is a rotation of vermis. Please remember this point, because you cannot every time see the location of the fourth choroid plexus unless there is some rotation, because when there is a rotation, then you can see the fourth ventricle clearly. When there is a clear visualization of the fourth ventricle, then you can identify the fourth ventricle choroid plexus. Now, as we know, the Blake's cyst arises from the posterior membranous area. Vermis arises from the anterior membranous area, and whenever there is a Blake's pouch which does not insinuate or evaginate or then perforate to communicate the fourth ventricle into the cisterna magna, then it forms what is called as the Blake's cyst. So whenever there is a Blake's cyst, it tries to elevate the fourth ventricle. As the fourth ventricle is being elevated, you can see that the fourth ventricle choroid plexus will be placed above and superior-laterally. Whereas in vermis, it is only the size of the vermis which is reduced. So it has no relation with the fourth ventricle choroid plexus. That is the reason why you normally see the fourth ventricle choroid plexus inferior-laterally. So that is what is very, very important. And this is the one point which has been useful in differentiating one from the other. So the present concept is that we need to depend on the ratio of, particularly the ratio of vermian area to the biparietal diameter. The cutoff is 1.1. And the second important factor is the location of the choroid plexus. In Blake spout cyst, it is superolateral, whereas in choroid plexus, the Dandy Walker as well as the Variman hyperplasia, it is inferiolateral. And we know the pathophysiology, why the choroid plexus of the fourth ventricle gets displaced based on the pathology involved. Now, so the learning points are the VA by that is the Vermian area by biparietal diameter is an important factor which will tell us to differentiate, but particularly between the Variman hyperplasia and the Blake spout cyst, because there is a lot of overlap. The second one, most important thing, is that the fourth ventricle choroid plexus, where it is superolateral in Blake spout cyst, whereas it is inferolateral in the Vermian hyperplasia as well as the Dandy Walker malformation. Now, coming to the morphology of the brainstem. Now, till now, we have already understood what the posterior fossa, particularly the hindbrain morphology biometry is concerned. Now, let us get into the morphology of the brainstem, that is the midbrain, where we can see the thalamus. By this particular section, we can beautifully see the thalamus. You can see the aqueduct. You can see the midbrain, pons, and then the medulla oblongata. You can see the fourth ventricle, that is the fastigium, that is the vermis. So we can measure all these structures. These are the things that we can usually do. We can take the tectal length, we can take the AP diameter of the midbrain, we can take the pontine diameter, as well as the AP diameter of the fourth ventricle. All these measurements can be taken by taking this particular section, and this will help us in identifying the biometry of the hindbrain. So the morphology of the hindbrain, which has been very clearly delineated by taking an appropriate section where you can demonstrate the thalamus, you can demonstrate the midbrain, you can demonstrate the pons as well as the medulla oblongata. And the measurements, these are the measurements which will help us to identify the hindbrain, midbrain abnormalities. Now, we have certain index features which are going to present to us. Tomorrow morning, when you go start evaluating the fetal brain, particularly when you are sent to a patient where there is a suspicion of a posterior fossa lesion, the index features are, it could be presenting with a large cisterna magna, or it could be presenting with an open fourth ventricle, or it can be presenting with a small Vermian biometry as well as the abnormal morphology, which accounts to almost 95% of the posterior fossa lesions. And then it can be a thin or flat pons, which can accommodate to account to about 71%, or the transcerebellar diameter, which is less than 10 centile, severe ventriculomegaly, or the abnormal tectal plate, brainstem kinking. All these features are the index features that will be identified initially, and further evaluation has to be done, keeping these index findings, and as they alert us to evaluate the posterior fossa thoroughly. Now, this is a classical case where we have the posterior fossa, particularly the megacisterna magna, where, as you know, the megacisterna magna or the cisterna magna is measured from the midpoint, that is the vermis, to the inner aspect of the occipital bone, and it should not be more than 10 millimeters. Anything more than 10 millimeters, as you can see here, is about 14 millimeters. It indicates that it is a megacisterna magna. Not only that, you can also take the transcerebellar distance, because that usually corresponds to the gestational age up to 26 weeks of gestation. And in this particular section, you can also see the vermis as well as the fourth ventricle very clearly delineated. And in this one, you can see that the fourth ventricle is lateral to lateral more than the AP diameter of the fourth ventricle. So these are the features which you try to evaluate as far as the cisterna magna or the intercerebellar distance and the fourth ventricle in the axial section is concerned. Now, as far as the megacisterna magna, quite often it's a benign condition where we find that the cisterna magna is enlarged or increased in size. But then you need to, before you label them as a megacisterna magna, you need to rule out various other possibilities which can be responsible to be presenting as a large cisterna magna, such as either an arachnoid cyst or it's a Blake spout cyst, have to be kept in mind. Now, particularly when you take the arachnoid cyst, as we know, it is the duplication of the arachnoid membrane, and it is filled with fluid. At the same time, they do not communicate with the fourth ventricle. This is one of the most important factors which you have to keep in mind, or the subarachnoid space. That is one. Second thing is, quite often it is actually a retrocerebellar cystic space occupying lesion, which is eccentrically located, displacing the cerebellum to one side. And this is what is classical of a infratentorial of midline arachnoid cyst in the posterior fossa. Now, coming to the Blake spout cyst, as we all know, the Blake spout cyst is nothing but because of the failure of perforation or communication between the fourth ventricle and the cisterna magna. This results in a large cystic area, which is called as the Blake spout cyst. Now, as I said before, it is essential that you need to differentiate between a megacisterna magna as well as the Blake spot cyst. Remember, as the Blake spot cyst is nothing but a communication or a continuation of the fourth ventricle. The fluid in the fourth ventricle is CSF. That is the reason why it is not corpusculated. Whereas the cisterna magna is subarachnoid space where it is usually corpusculated. So that is how you differentiate one from the other as far as the axial scan is concerned. When you take a sagittal section, you can see beautifully that there is a mild rotation. The morphology is absolutely normal. The size is normal, except that there is a mild rotation and a large cystic area, which is communicating the fourth ventricle with the cisterna magna. And that has actually resulted in a cystic dilatation. And you can see the choroid plexus, which are actually placed up superolaterally, which is extremely important in this particular case, where you can see that, sorry. You can see them as the superolaterally displaced. So this is how you identify the Blake spot cyst. Now coming to the cerebellum, whenever we try to evaluate the cerebellum, there are 4 points which we have to keep in mind. One, the size, that is identified by transcerebellar distance, symmetry of the cerebellum, as well as the echogenicity and foliation of the cerebellum. These are the things that will prompt us to think in terms of. Usually, the cerebellar hyperplasia unilateral cerebellar hyperplasia is much more commoner than the bilateral one. And whenever you have the transcerebellar distance, which is less than 10th centile, as you can see here, it is very, very suggestive of a cerebellar hyperplasia. This is actually a bilateral cerebellar hyperplasia. Remember, the cerebellar hyperplasia is an evolving abnormality. That is, in the initial scans, that is the early mid-trimester scan, that is let it be about 20 to 22 weeks of gestation. Quite often you may have a normal cerebellum, but as it progresses to late mid-trimester or the third trimester scan, you find suddenly finding that the transcerebellar distance corresponds to less than 10 centile, which is highly suggestive of a cerebellar hyperplasia. Now, these are associated with aneuploidies such as the trisomy 13, and not only that, there are certain genetic syndromes which we have to keep in mind whenever we come across this sort of a cerebellar hyperplasia. Now, coming to the Vermian abnormalities, the most important thing is the Vermian hyperplasia, that is the small vermis, or we may have what is called as the Dandy Walker malformation, which is nothing but there is a small vermis, but at the same time it is rotated as well as elevating the tentorium, and then the Jobertson, which is again a variant which has to be kept in mind. Now, coming to the small vermis, in all these three conditions, what we find is that the vermis is small. Whenever we find the small vermis or a Vermian hyperplasia, the most important thing is it could be because of genetic or clastic or a hemorrhage into the vermis, which is responsible for a small vermis. But there has been a lot of research that has taken place where it has been stated that first trimester excess vitamin A is also an iatrogenic cause for a small vermis. This is one thing which has been recently published in White Journal, where they have found that the excess vitamin A usage in the first trimester has resulted in vitamin hyperplasia. Now, when we call it as a small vermis, when do we call it as a small vermis? We call it whenever the vermin area by biparietal diameter ratio is less than 1.1. That is one aspect of it. The second important thing is, that is as far as the biometry is concerned. Coming to the morphology is concerned, the normal landmarks of the vermis, that is the fastigium, primary fissure, cannot be identified. So the size is altered, morphology is altered, but the most important thing is tentorium is absolutely at the normal location. And the BV angle, if you want to take it into consideration, it will be more than 50 degrees, and the fourth ventricle choroid plexus will be located in inferior-lateral position. So basically, we want to go by the biometry. We want to go by the location of the fourth ventricle. We want to go by the obliteration of the normal landmarks, that is the morphology of the vermis. Now, then comes the, this is how a classical Vermian hyperplasia looks like, where you can see that the vermis is absolutely small, and you can see that this is the inferior-lateral position of the choroid plexus, that is the fourth ventricle, that is the inferior-lateral portion of the fourth ventricle, the choroid plexus of the fourth ventricle, with absolute hypoplastic vermis, which cannot be demonstrated as a nodule also. So it was a severe hyperplasia of the vermis. Now, coming to the other causes of, most important thing is this Vermian hyperplasia. We have to keep in mind that they are associated with almost 60% of central nervous system abnormalities, such as the agenesis of corpus callosum, or it can also be associated with non-central nervous system abnormalities. The chromosomal abnormalities are very, very rare. That is only account to about 1% of the abnormalities as far as the Vermin hypoplasia is concerned. Now, coming to the Dandy-Walker malformation, quite often on the axial view, what we find is an open, wide, V-shaped, open fourth ventricle. Not only that, there will be an elevated tentorium or the auricular hierophyly. On the axial view, what we find is we can find the beaking of the tentorium, which is very, very typical of a Dandy-Walker malformation. Then we have a small vermis where you can have the biometry wise, it will be less than 1.1. The coronal section shows that the fourth ventricular choroid plexus is inferolaterally. So this is how it happens, and then this is classical. In the axial view, you can find that there is a wide open fourth ventricle. This is what is called as the tentorial beaking. There will be ventriculomegaly associated, and you can see a beautifully demonstrated vermis, which is absolutely small, rotated upwards, and there is a large BV angle. At the same time, you can see the tentorium being elevated up. This is what is called as the rat tail appearance also, as far as the posterior fossa is concerned, and then the Dandy-Walker malformation is concerned. So these are the classical features as far as the Dandy-Walker malformation is concerned. Remember, they are also associated with central nervous system abnormalities like complete agenesis of corpus callosum, certain non-CNS abnormalities, and the incidence of chromosomal abnormalities is very, very high. It is almost about 16.3%. So that is the reason why we need to be careful whenever we try to identify this sort of abnormalities in the posterior fossa. It is essential that we need to evaluate for the chromosomal abnormalities also. Now, coming to the Joubert, it is very difficult to diagnose prenatally. The most important thing is the vermis is severely hypoplastic or agenetic. So whenever you take a midline section, actually this is a mid-sagittal section, what actually you are seeing is the cerebellum and not the vermis. So because of the close approximation of the cerebellar pedicles, you get what is called as the molar tooth sign, which is usually seen either in the coronal or the axial section. In the molar tooth, the crown is usually because of the deep interpedicular fossa, whereas the roots are because of the thickened superior cerebellar peduncle. So this is what causes the molar tooth sign, and the fourth ventricle diameter will be actually increased from. This is very, very important. As I said, it is always the lateral diameter which is there, whereas the lateral diameter will be more than the anterior diameter. Here you can find that the lateral diameter less and the AP diameter becomes more. So as you can see here, you can see a slit-like structure of the fourth ventricle. These are the classical deep interpedicular fossa with the prominent or hypertrophied cerebellar peduncles, which you can see by taking a coronal section. This is actually the axial section where you can see that this is the slit-like, lateral to lateral is less, AP is more, and you can see the deep interpedicular fossa and a hypertrophied superior cerebellar peduncles. And this is how, when you take a cut section, this is how it appears as far as the molar tooth is concerned. This patient was subjected for MRI. In MRI, we could find that there is a molar tooth sign positive. So this is how you evaluate as far as the the Joubert's is concerned. Now coming to the rhombencephalosynopsis, where there is cerebellar fusion, you find that both the cerebellar hemispheres are fused, in which you find absolutely small or nodular vermis. Sometimes you don't even find that vermis, and it can be this rhombencephalosynopsis can be complete or partial. If it is complete, you have complete agenesis of the vermis. If it is partial, you may have what is called as a small nodular vermis. Here again, the AP diameter of the fourth ventricle will be more than the lateral diameters, and normal dumbbell-shaped or 8-figure of the cerebellar hemispheres are lost, and what you find is actually a triangular appearing cerebellar hemispheres because of rhombencephalosynopsis. Now coming to the flat pons, here you can see beautifully the pons is absolutely flattened. So suppose you take a biometry also, it positively shows that there is absolutely small flattened pons, which is classical of a pontocerebellar hypoplasia. You have to keep in mind that the CASC gene is the one which could be responsible for this sort of a presentation. Now coming to the elongated tectal plate, particularly the Chiari-2 malformation, where whenever you have an occipital cerebral encephaloceles or cephaloceles, what happens is because of the traction, the AP diameter of the midbrain becomes more. not only the tectal line becomes elongated. So these are the two features which tells us about the Chiari-2 malformation. And sometimes you can find, this is the classical kinking of the, as we all know, from about 16 weeks onwards, you should not find this sort of kinking of the midbrain and brainstem. And if you find this sort of a kinking, you can see that this is a Z-shaped structure, which is very classically seen, which is typical of a walk-a-wobber, that is the cobblestone malformation complex, which we have to keep in mind. Now, not only that, in walk-a-wobber, what we find is that it is actually the outer agoric echogenic bland. So you can see that these are very, very echogenic tectal plates. At the same time, you can see the cortical thing, very echogenic cortex all around. At the same time, there is a reduction or disappearance of the pericerebellar space, absolutely no space around, and with a G-shaped brainstem, which is very, very classical of a walk-a-wobber syndrome. So I will just take you through one or two slides, that's all, because already the posterior fossa first trimester has been already evaluated. Basically, whenever you try to evaluate the various structures as far as the posterior fossa concerned. This is the choroid plexus of the fourth ventricle. The size of the fourth ventricle can also be of great importance, because any alteration in the size of the fourth ventricle is a very, very important marker as far as the posterior fossa lesions are concerned. One, it could be suggestive of a posterior fossa cystic space occupying lesion. Two, it could be because of an aneuploidy. So these are the two things that, what is normal posterior fossa? The fourth ventricle, when you take the AP diameter, which should be not more than 19. If it is more than 19, or if it is 25, it corresponds to 95th centile, which is highly suggestive of a posterior fossa space occupying lesion. As you can see here, there is a large cystic area in the posterior fossa, and on the transvaginal scan, you can find that the fourth ventricle is absolutely large and dilated, and you can see that the choroid plexus is absolutely absent. So that is the occipital bone. Now, this is again another case where we can see that that is the aqueduct, and you can see a large cystic space occupying lesion in the posterior fossa, which could, when this patient has to be followed up, because this was done recently, and I have asked them to come back. Probably we will follow up, but then the basic suspicion was a possible posterior fossa cystic lesion because of the dandy walker malformation. Now, this is a small chart which can give us about the various index features. That is, quite often the posterior fossa lesions present with lenticulomegaly, cisterna magna dilatation or smallness, area of the vermis, vermian rotation, tentorial location, location of the fourth ventricle choroid plexus, and then the BV angle, and various abnormalities. So these are all the various abnormalities that you come across in the posterior fossa. These are the index features. What will happen in these things? You can take a snap of this so that it will be useful to you in day-to-day evaluation. So with this, I think I'll end my talk saying that the posterior fossa lesions are not common, but then they vary from a normal variation to a severe abnormalities, and thorough evaluation of the posterior fossa. The specific technique has to be followed in your identifying various midbrain and hindbrain structures. Their morphology, the biometry are extremely important. And with this, I would like to conclude, and thank you very much for a patient listening. And I would like to invite you all for tomorrow's webinar. We have a galaxy of speakers. We have speakers who are stalwarts in various aspects of fetal medicine, and at the same time, we have been trying to encourage younger generation, the future legends, as Dr. Ashok always calls them, as the future legends. And he was the one who has initiated this program in order to accommodate as many young talents as possible and encourage them to become future legends in our field of fetal medicine. Thank you very much. Thank you, Ashok.
Thank you. Thank you, Dr. Praveen, for that fantastic talk and for updating us on how much we have moved on actually in the world of the posterior cranial fossa from where we were just 2 years ago. And the first question for you, I think you already answered twice over. This is from Dr. Balaji. The normal, the vermis area to BPD range. And you already told us that that's 1.1, and that's what we can follow. So that is a fantastic answer already. Then we have some questions here, which are for Dr. Rachita. And the first one of these is, what are the causes of a unilateral ventriculomegaly?
Unilateral ventriculomegaly specific causes are, say, suppose a mass lesion like the one I showed, which is obstructing the foramen of Monro. It could be a bleed, germinal matrix bleed, intraventricular extension and causing that vein to enlarge. It can be a cerebral hemispheric abnormality. If one hemisphere is large, like in megalencephaly, that hemisphere will have a larger ventricle. If a hemisphere is abnormally small as well, if the cerebral cortex is atrophic, like in a Dyke-Davidoff-Masson syndrome, where the cortex is very thin and atrophic, that will cause a unilateral ventriculomegaly. But these are specific causes. Generally, unilateral ventriculomegaly can also be seen in any of the other causes that can cause bilateral ventriculomegaly as well. So the protocol that we must follow should include everything that we do for bilateral ventriculomegaly.
Wonderful. And the second question is, what are the cutoffs for first trimester ventriculomegaly, subjective or objective?
Generally, we follow a subjective method. There's no a fixed cutoff like 10 millimeters in the second and third trimester. It's mainly by the appearance of the choroid plexuses. If the choroid plexuses are looking bulky and a nice butterfly shape, and we don't see too much anechoic area around it, then it's not ventriculomegaly. If at all we're seeing bunched up choroid plexus that are discretely seen with too much fluid around it, then we must suspect ventriculomegaly in the first trimester. There have been articles showing us the normal cerebral choroid plexus ratio, area of the choroid plexus to area of the lateral ventricle ratio and width ratios, but generally it's just subjective.
Thank you for that very nice, clean answer. There's also a question on, can TVS very easily sort out a pseudo-hydrocephalus?
Yes, if the head is a lower pole, we could, but I think we've reached a stage with our machines where we shouldn't really be diagnosing pseudohydrocephalus at all. Our machines are good enough these days, and we must optimize our images well enough so that we see the lateral ventricular walls separately from the cerebral hemispheric walls, surfaces. So we only must measure the ventricle, and pseudohydrocephalus is, I think, a thing of the past now. But yes, a transvaginal neurosonogram is definitely the best course.
Okay. And then we have a question here that's going to truly give value for money for those of us who are still attending this, and that is from Aparna Setia. And Aparna wants to know if fetal infection is the cause of ventriculomegaly, and it's way later in pregnancy, where it's way beyond termination, then why should we bother to do these follow-ups that you were suggesting?
That's philosophical.
Yeah, that's if we want to monitor the case, if there is no option for termination, you want to still monitor the progress, see what is happening. It's our job to suggest it.
Yes.
Whether to do it or not is definitely left up to the couple.
Yes, and for those of us who read a charming newspaper called the Mumbai Mirror, you would have read day before yesterday that thanks to all the efforts we made through 2018 and 2019, we actually got court permission to terminate a 32-week complex cardiac anomaly on last week. And it's amazing. We had to work on this together. The Society of Fetal Medicine worked together with FOGSI, and we attended, I think, 150 meetings at the Health Ministry, and we worked our way through every one of the NGOs who was objecting to this. And while we were waiting for the MTP law, which anyway will have no connection with this, we were able to release a legal document called a guidance note for late termination of anomalous fetuses. And Dr. Jaideep Malhotra, who was then the FOGSI president, was absolutely instrumental in pushing our agenda forward, that we do not anyway have to go to the High Court anymore. We go to the district court that appoints an actual medical board from people available in the same city, preferably from a government organization. And within a week, the court gives a yes or a no to that termination as guided by the board and as guided by the wisdom of the judges, of course. And so we now have this guidance note that we can all use. We've had at least 19 judgments from West Bengal, 7 or 8 judgments from Maharashtra, and some random judgments from the rest of the country. So we have about 26 judgments already, and we can guide our patient that this is possible, that there is a timeline on this in spite of COVID times. We have managed this. This patient, of course, took a longer time. She started The first diagnosis was given to her at the end of August, and she took 5 opinions before she made up her mind, but understandably so. And then she got permission at 32 weeks, and she's had a successful termination, and she's safe, and things have worked well. So we must remember that there is this silver lining. Chinmay wants to add something to this.
Yes, sir. So apart from the fact, like you rightly pointed out, there is a scope for late terminations. The fact that this was because of infection is an important thing to determine in this pregnancy, because one, if it is like something like toxoplasmosis, there is some form of treatment available. Any infection diagnosed antenatally would lead to a quick postnatal follow-up on that. And for prognosis sake, her future pregnancy, she's little better off if it is because of an intrauterine infection this time, because these don't happen as recurrent cases. Whereas if it would be one of the genetic causes, like Rachita had said, there could be a chance of recurrence, higher chance of recurrence. So working up is not something we should desist from, whatever gestation we are met with an anomaly.
Yes, and this is very important from a counseling point of view. So I'm so glad Dr. Aparna brought up this question so that we could take this up before we close tonight. I'm just checking to see whether there is any other question left for us, and we seem to have gone through all the questions. I'm just taking a last minute look at the chat box, and here we go. We seem to be through with that, and so I'd like to take this chance to actually thank everyone who has been with us this evening. My first thanks always goes to Dr. Hasmukh Clark for having founded the Odisha chapter, for being the catalyst, for always being managed to get things, and a marvelous two-day event like this spread out and with excellently covered by faculty. We have got permission to be able to put some of this already on our YouTube channel, but we will wait for all the permissions and hopefully we will get them. I'd also like to thank specifically the excellent teamwork by the Odisha chapter led by Dr. K.C. Mahapatra, and with Preeti as the active head, for pushing forward all the secretarial work and always giving us excellent programs, and the entire team from Odisha. Also, this chance to thank the Sonologists Association of Odisha. They're always extremely supportive, and Dr. Surendra Prasad Das is as active on both sides, and I know it's happy for us to be as active on both sides. And thank you very much indeed, my friend, for being out with us all night. I'd also like to take this chance to thank our trade partners, LifeCell, GE, as well as Buck and Elmer, for this support that they give us. It helps us to bring this program free of cost to members as well as non-members. And of course, as you can see, Vishal Mittal looking completely washed out today because he's been up since 5 o'clock and is now going to be ready for us at 9:30 tomorrow morning. 9:30 is a very active program. Dr. T.L. Praveen has mastered a beautiful list of speakers for you, and we look forward to that. And of course, Conferences International and Sumit Ghai will also be up well and early to guide us through tomorrow, which is again going to be a hectic day. Thank you very much. And back to Preeti for final words.
I would like to congratulate the Odisha chapter, Dr. P.C. Mahapatra, Kishore K.C. Mahapatra, as well as Preeti Dubey and Hasmukh Lal for organizing such a wonderful event. Thank you once again.
For all of you, I can say, सूरज रे जलते रहना. इसी तरह से darkness को dispel कीजिए. All the darkness we have in the gap in knowledge, you people have to show us the light. Thank you.
Thank you. Good night.
Thank you. Thank you everyone for attending this wonderful conference and making it more successful. Thank you, sir.
Thank you. Thank you very much.
Thank you, ma'am. Thank you, sir.
Congratulations, everyone. My special thanks to the faculty. Good night.
Thank you, sir.
Good night.